Hello friends, welcome to the LRR session for the upcoming INI-CET exam. I hope your preparation is going full-fledged. So yes, it has started. Aspire for Moon. It's a very nice name that you have there. We are ready, and yes, I am also ready. Good afternoon, Shivendra Ravi. So how is the preparation going, Arshia? Hello. Good afternoon, everybody. Good afternoon, Amit. Sandhya, good day to you too. So what we are going to do in today's LRR session is, I don't want to, Dr. Rahul, good afternoon. Welcome everybody. Yes. So what we are going to do in today's LRR session is, I have curated some very important previous year topics, right? My focus is going to be on the most important previous year topics, considering the trend of the examination that has been ongoing. I have also taken the liberty of, one-upping the questions. So what I have done is, some of the questions are exact PYQs, but some of the questions I feel that INI-CET particularly, one-ups their game, in the sense that they would ask a question in the previous exams and then, they would one-up it, and next time they would frame a similar question which you may think is a direct repeat, but turns out it isn't. So I've taken the liberty of tweaking the options a little bit, so that is going to make you think in today's session, right? And any other questions apart from the questions that I have for today? If you have any other questions, you put it in the chat box and I'm going to look that up as well. Okay, fine. All right. Now, Sanvi, ovarian diseases is a very broad area. I will give you important pointers regarding the, you have to be very specific in asking your question. Ovarian diseases altogether is a very huge area that you're asking, right? And updates, yes. I have roped in the questions. I've framed some new questions, trying to figure out how those updates potentially may be asked in questions at the most. So relevant updates, I'm going to take that up also. I am going to take up the relevant updates, and yes, it is going to be helpful for NEET PG too. So those of you who are not appearing for INI-CET but for NEET PG, you'll find these updates, these previous year topics, they remain the same across the different examinations. Okay, maybe difficulty level here and there may be slightly different, but the topics essentially remain the same. All right, so let's get started without wasting any further time. Let's have a look at the first question of the day. There's a 35-year-old primee who underwent an NT-NB scan at 12 weeks. Nasal bone is absent and nuchal translucency is markedly raised and septated, leading to suspicion of cystic hygroma. What is the most appropriate next step in the management? No, it is not anencephaly. No, it is not anencephaly. They are telling you that nuchal translucency is markedly raised and septated, okay? So this is not anencephaly. Okay, this is the baby's scalp that you are seeing. That's fine. But there is this. Yep. This area we are talking about. Okay, so this is the swelling behind the nape of the neck. Okay, clear swelling. So cystic hygroma is actually a veno-lymphatic malformation. Now you will wonder that nuchal translucency also looks similar. Okay, and that's correct. Nuchal translucency will also look similar, but the thing about cystic hygroma would be that it will probably extend along the back also. It tends to be much larger and it tends to be septated also. That's why they are saying suspicion of cystic hygroma. Okay, that's why they are saying suspicion of cystic hygroma. Okay. Right. And another important feature about cystic hygroma, another important differentiating feature is that cystic hygroma tends to keep on enlarging, all right. So it is going to persist even beyond 14 weeks. And cystic hygroma itself is a major anomaly. It's a major anomaly. It's not a soft marker. I mean, raised nuchal translucency, absent nasal bone, these are soft markers. But cystic hygroma is a major anomaly with a significant underlying association with aneuploidies. Like you guys are mentioning that yes, it is associated with Down syndrome also, it is associated with monosomy X also, right? So there's a significant association with aneuploidies, significant association with aneuploidies. And now she is 12 weeks, right? So because of this reason, we need an invasive fetal testing to confirm the diagnosis, right? So the most appropriate next step in management therefore would be chorionic villus sampling. Okay, so chorionic villus sampling you people are choosing, that is the correct answer. And now you know why it is not D. Okay, so at the moment she's 12 weeks, we have detected it, best would be to go for invasive fetal sampling. And yes, maybe invasive fetal sampling does not yield any such result of aneuploidy, and then yes, later on further evaluation like targeted sonography, because this cystic hygroma could be associated with other gross major congenital anomalies. That is if the patient continues the pregnancy, right? It can also be associated with your congenital heart diseases of various kinds, and therefore fetal echo would also be needed eventually, right? So yes, as the workup right now, it needs chorionic villus sampling for now, which can be done very safely between 10 to 14 weeks of gestation. Okay. Now, the next question. A 25-year-old woman presents with amenorrhea for 6 weeks, crampy lower abdominal pain and mild vaginal bleeding for past 2 days. Her vitals are stable, beta HCG is 1500. Which of the following will support the diagnosis of ectopic pregnancy in this woman? So you have got 4 choices and you have to pick. This is multiple options are correct, right? So yes, pick yes. So empty uterus on transvaginal sonography would be the first clue in this situation, right? So option C I can eliminate. Option C I can eliminate, right? Now we are getting answers like option number A, some of you are saying D, some of you are saying B. Well, come to think of it, bache, free fluid on in pouch of Douglas can be there, no, some bleeding if happens, right? She is otherwise stable, right? See, stability, hemodynamic stability depends on how much blood loss has already been lost in the process, right? So maybe there is not too much blood loss and she happens to be hemodynamically stable, right? So yes, free fluid in pouch of Douglas in this particular context will point towards maybe blood in the pelvic cavity, right? So yes, blood will collect first in the pouch of Douglas. So free fluid in pouch of Douglas will point towards blood. Adnexal mass on TVS can be appreciated, right? So yes, 1, 2 and 3. These are going to support the diagnosis of ectopic pregnancy in this woman. So answer is B. All right. So you understand why option number 3 is also included, free fluid in pouch of Douglas, right? Now, for those of you who are saying option number D, for those of you who are saying option number D, see, low serum progesterone is not going to support the diagnosis of ectopic pregnancy. All low serum progesterone is going to say is that it is a failing pregnancy. Low serum progesterone will not give an idea about location. Okay, so serum progesterones will be high, will be in the normal range, right? So serum progesterone levels more than 25 nanogram per deciliter. You need not remember the value, but understand that higher serum progesterone levels are associated with a normal, live, intrauterine pregnancy, and low serum progesterone levels than expected can be there in ectopic also, can be there in a failing intrauterine pregnancy, in an aborting pregnancy also. So it does not give us idea about location. So it does not support the diagnosis of ectopic pregnancy. Keep that in mind. And anyways, we are not doing serum progesterone levels to make the diagnosis of ectopic any which ways, right? Okay. So this is not the answer. Now, Doc Panda, you want to know about beta HCG levels in different scenarios. So beta HCG levels in different scenarios would be basically about early pregnancy situations till the time that the peak beta HCG levels are reached 8 to 10 weeks. So during that time, what we see is that there is doubling of beta HCG levels, right? So in early pregnancy, doubling of beta HCG values, and this doubling has to be seen every 48 hours. So this can only be seen on serial beta HCG monitoring, which is done every 48 hours. So doubling of beta HCG will be suggestive of healthy intrauterine pregnancy, and your plateauing levels are suggestive of ectopic, and dramatically falling levels more than 50% are suggestive of failing intrauterine pregnancy. So that is the trend that tends to happen, and this gives us an idea about the location of pregnancy. So this serial beta HCG monitoring is used for evaluation of pregnancy of unknown location, right? So when you have a situation where there is pregnancy of unknown location, okay, then in that situation, serial serum beta HCG monitoring is done. Okay. Now, GSAC is earliest visible at 1000 HCG, but most commonly 2000 on TVS. Yes. So again, now see, the discriminatory zones of beta HCG at which a GSAC becomes visible, that has been consistently changing, right? So 1500 approximately, 1500 to 1000 international units per liter for transvaginal sonography has been the discriminatory zone. That means by this time the gestational sac, wherever it is, should be visible. When we are monitoring pregnancy of unknown locations, particularly when a woman is keen on keeping the pregnancy, particularly if the woman is asymptomatic or maybe mildly symptomatic, the question isn't how soon you are able to see the sac. The question is, how long can one keep waiting? How long, till what beta HCG levels can one keep waiting for the sac to appear on ultrasound, right? So nowadays, yes, nowadays there is a new discriminatory zone. Nowadays they are saying that one should raise the discriminatory zone threshold to 3500 international units per liter for transvaginal sonography. All right, fine. And yes, molar pregnancy will have excessively raised beta HCG levels. Molar pregnancy will have excessively raised beta HCG levels. Okay, Saida? Fine. Any doubts about this question? So yes, we have one doubt saying that D is possible. I am telling you that D is not the best answer to choose, because of option number D is not the best answer to choose, because low serum progesterone levels will not give you any idea about the location of pregnancy. All right. So it will not support the diagnosis of ectopic pregnancy. Clear? Now let's have a look at the next question. There's a 24-year-old primey at 6 weeks of amenorrhea and she's diagnosed with left-sided tubal ectopic. Her vitals are stable, serum beta HCG is 2500. Transvaginal sonography shows a left-sided complex adnexal mass of 3 centimeter size. She is compliant for follow-up, not complaint, she is compliant for follow-up, willing for follow-up. Her baseline CBC, LFT, KFT reports are normal. Intramuscular injection of methotrexate is given. She is advised all of the following except what is she not advised? In INI-CET, bache, do not miss out on all except, okay? So this is one thing that sometimes you make a mistake. Think again. She is advised all of the following except what will you not advise her? I still haven't got the right answer from you people. I still haven't gotten the right answer from you people. When I'll tell you the answer, you'll realize, oh, think about it. Yes, so Doraemon is saying A. Why are you saying A? The one who is saying A, why are you saying A? And then I'll eliminate the other options for you as well. Yes, Dr. Bella. Yes, Dr. Strange. Why is the answer A? She is advised all of the following except. Okay, so folinic acid is given, not folic acid. Excellent, Bhanu Prakash. Methotrexate inhibit dihydrofolate reductase enzyme, right? As it is not a normal pregnancy, as it is going to abort. Think about it. You are giving methotrexate, right? You're giving methotrexate intramuscular injection, okay? You're giving it systemically, all right? Now, how does it work? What is the mechanism of action of methotrexate? So, I got the right answer from Bhanu Prakash here. It is a dihydrofolate reductase, right? So, if you're going to, so these women who are actually trying to get pregnant, they are, maybe she's already taking folic acid, they're already on folic acid, right? So, if she's going to continue folic acid, it is going to interfere with the mechanism of action of this drug, right? So, you don't continue oral folic acid, you stop oral folic acid. So, she's advised all of the following except this. All right. She's asked to avoid exertion. She's asked to avoid intercourse, right? So, when we are doing medical management of ectopic pregnancy, she has to be on long follow-up. Medical management of ectopic is not a 100% guarantee that during the course of medical management, the ectopic will not rupture at all. There is still risk of rupture. However, that is mild. But then again, you know, she's asked to avoid exertion, avoid intercourse, lest it may, you know, maybe it can, cause rupture of the ectopic. So, that precaution needs to be taken. So, she is advised to avoid intercourse, yes, okay. And serum beta HCG has to be repeated on day 4 and day 7 also. So, we've done a baseline serum beta HCG. We've done a baseline serum beta HCG on day 1. We have given the injection methotrexate and then we repeat the serum beta HCG on day 4 and day 7. Now, between day 4 and day 7, right, between day 4 and day 7, at least 15% fall. Between these two values, there should be at least 15% fall in the beta HCG values. So, if at least 15% fall is there, then we have to continue beta HCG weekly till the levels become normal, right? And if the fall in beta HCG is not there, then we can add another dose of methotrexate. So, generally for ectopic pregnancy, we go with the mindset that we are going to go for a single dose therapy. Okay. So, generally when we give medical management for ectopic pregnancy, we start with a single dose mindset. That is why folinic acid is not given. You know, folinic acid you give when we go for methotrexate therapy, when we are giving multi-dose methotrexate therapy. And that you must have read in the management of gestational trophoblastic neoplasia, when we are giving chemotherapy for that purpose. So, when you have to give alternate day methotrexate, then we alternate it with folinic acid to avoid the side effects or to prevent the side effects of systemic side effects of methotrexate therapy. So keep that in mind. And anti-D injection, if she's Rh negative, that also needs to be given. Okay, so even in ectopic pregnancy managements, if the patient is Rh negative, then anti-D injection has to be given. So this is also yes, this is also yes. All of these are advised except continuing folic acid. All right, clear? So now you can understand that. Now you can understand why leucovorin at this point in time is not not going to be the answer. So when we are going for ectopic pregnancy medical management, we start with the single dose only. So we are not giving leucovorin along with it. In situations when we are giving multi-dose methotrexate therapies, like when we give for GTN, there we alternate methotrexate with leucovorin. Okay, so keep that in mind. Now let's have a look at the next question. A woman is seen at 12 weeks of gestation with complaints of mild spotting. Ultrasound reveals a gestational sac of 5 weeks gestation. So the sac diameter has been measured. Okay, so sac diameter, mean sac diameter to be very precise, can be measured and we can get an idea about the weeks of gestation. There is also fetal pole measuring 10 mm in CRL, but there is absent cardiac activity. What is the diagnosis? I tend to find this is one question that I always discuss in my lectures. Okay, and I always find people who get confused about the different types of ectopics. All right, so for those of you who are saying inevitable abortion, that is absolutely incorrect. Because what is inevitable abortion? Inevitable abortion meaning at least the process of expulsion has started. Here she just has mild spotting. That's all. The entire sac, gestational sac with the fetal pole is inside the uterus. It's a dead retained sac inside. It's a probably a dead retained fetus inside, because beyond a certain point the cardiac activity has not appeared. It's already a CRL measuring 10 mm. So this is missed abortion. This is missed abortion. Yes. So there are two important ways we diagnose missed abortion or early pregnancy loss, which is typically an ultrasound diagnosis. And like you're already mentioning that CRL more than or equal to 7 mm and yet there is no cardiac activity, that is one way. And the second is that maybe there is a gestational sac with a mean sac diameter of 25 mm or more and still it is empty. That would make the diagnosis of early pregnancy loss, right? Now, let's also appreciate the differences between threatened, inevitable, incomplete and complete abortion. Okay. Now see, there are distinct clinical scenarios on which potential questions can be asked. Okay. Beyond that, I don't think there is any other scenario to be asked from undergraduate students, right? So let's go through it quickly. So when there is a threat of abortion, there's just a threat, the process of expulsion has not started, right? So the bleeding is going to be mild, maybe just spotting, okay, and pain is going to be off and off. She may or may not have off and on cramping lower abdominal pain. Naturally, she's not losing blood at significantly, so vitals are obviously stable. All the products of conception. Now see, threatened, inevitable, incomplete, complete. It could be in the first trimester, it could be in the second trimester, scenario could be anything. When I say products of conception, right? So when I'm talking about early pregnancy, it's the sac, it's the embryo, it's the fetus, right? When I'm talking about second trimester, there'll be a fetus, there'll be a placenta, right? So understand the logic. So whatever products of conception are there, they are all still inside the uterus in threatened abortion. So the size of the uterus is going to correspond to the period of gestation and the os is going to be closed, all right, and the diagnosis will have to be confirmed on transvaginal sonography when we have to see that the fetus or embryo is still inside and the cardiac activity has to be present. This is a very, very important point of differentiation, star market, between threatened versus missed abortion, threatened versus early pregnancy loss. One may get confused clinically whether it is a threatened or a missed abortion like situation, as we saw in the earlier question. How did we make the differentiating diagnosis? By doing the scan, right? So if in this scan there was cardiac activity present, it would have been a threatened abortion, but here cardiac activity is absent. That's why answer was missed abortion. So cardiac activity present is very, very important. The management is conservative, and reassure. Okay. Now, in inevitable abortion, inevitable means something that is inevitable means that it is bound to happen. It is going to happen. There is no going back. So, the process of expulsion has started. Bleeding has increased, pain has increased, vitals depending on how much blood she has already lost, may be stable, unstable, right? Now, the products are still inside. The process of expulsion has started, just started probably, but the contents are all still inside. So, size of the uterus is corresponding to the period of gestation. Os has started to open up. The contents are still inside. The fetus or the embryo is still completely inside the uterus, and cardiac activity present or absent will not matter now. It will not make a difference whether the cardiac activity is present or not. It doesn't matter if the fetus or embryo is already dead or not. It has started aborting. It is inevitable abortion. Now at this point in time, we are going to let it progress and we intervene if needed. If the woman is bleeding very heavily, if she's already having infection, then we will want to expedite or hasten the process of expulsion, and then we can go for suction and evacuation. So it will depend on situation to situation. So intervene if needed. Now incomplete abortion, meaning that the some of the products have been expelled, some of the products are still retained inside. Bleeding is more, pain is more, vital stable, unstable. Because part of the products are already expelled, naturally the size of the uterus is going to be less than the period of gestation. Okay. Now from here we can diverge to two situations. Situation number one, patient comes in the emergency, she is bleeding and she has a history of pain, she may be stable, unstable. Let's say, for example, we do a PV examination. On PV examination, the os is open and their POCs are felt in the vagina. POCs are felt in the vagina. That is situation number one. Now, the diagnosis is obvious on clinical examination. All right. Now, the diagnosis is obvious on clinical examination. Situation number two could be that the os has managed to closed. Situation number two is that the os has managed to closed. So now if there are still products remaining inside, we want to go for a scan, right? So then on transvaginal sonography, if we see retained products of conception, RPOCs, still present inside, the diagnosis is incomplete abortion. Okay, so now the management is evacuation of uterus. In complete abortion, there is going to be a history of bleeding, his history of excessive bleeding, pain, but now that has stopped. She may give history of passage of fleshy mass, may be stable, unstable, right? The size of the uterus is going to be much less than the period of gestation. Os has managed to close. And when we do a scan, so complete abortion has to be confirmed by a scan. The uterus is going to be empty. Uterus is going to be empty, and then evacuation of the uterus is not needed. But somebody who's a woman who has come with the complaint of vaginal bleeding with pregnancy, obviously you need to check the blood group, hemoglobin status in all of these women. Okay, don't forget that. Don't forget the resuscitation part of it also in either of these situations. Keep that in mind. All right. So this covers in brief your different clinical scenarios, and clinical based questions could be asked from here. Most of the times they do ask you about missed abortion is what they have been asking in recent examination, but in the past they've asked these clinical situations as well. Now let's look at the next question. A 25-year-old primey is seen in ANC OPD. Okay, Shubhi. Okay, before that, Shubhi is mentioning beta HCG should be titrated. See, Shubhi, with complete abortion, yes, I do teach it in my long lectures also, that when a clinical scenario is that very much likely of that of complete abortion, this history of passage of fleshy mass, sometimes patients bring the what they have passed, or sometimes patient may pass the fleshy mass in front of us, and then we can see chorionic villi, we can see the gestational sac. So if it is obviously we are looking at it, then the diagnosis is fairly certain. The other situation could be that she had a scan done earlier on in pregnancy. She already had a scan which had shown an intrauterine pregnancy. Then she had a bleeding. Then you repeated a scan and now the uterus is empty. So fairly certain that it was inside the uterus earlier. Now it is not. So it is complete abortion. The third scenario could be we are not certain what she passed. We are not certain what products were expelled. Then in those situations, yes, beta HCG monitoring 48 hours, one now, then another 48 hours later should be good enough, because then we can see this falling beta HCG falling more than 50% over 48 hours, and that would establish the diagnosis. Clear, Shubhi? I think that is what you were pointing at. All right. Now, next question. A 25-year-old primey is seen in ANC-OPD at 16 weeks. Her HB is 8 gram per deciliter. Peripheral smear shows microcytic hypochromic blood picture. HPLC report shows beta thalassemia trait. She is advised all of the following except, excellent, she is advised all of the following except parenteral iron therapy. So yes, she is anemic. Treatment of anemia is needed, but if there is thalassemia trait, we want to make sure that before giving parenteral iron, it is very, very important to check the iron stores. And with thalassemia, the iron stores are not deficient. So we don't want to overload with iron, no, because whatever parenteral iron we give, the logic of giving parenteral iron is that it goes and directly builds up the iron stores. Right. So parenteral iron therapy will not be given in thalassemias and hemoglobinopathies where iron stores are not deficient. So keep that in mind, and that is why before parenteral iron therapy, it is always very important to rule out hemoglobinopathies. It is always very important to check the serum ferritin, meaning that one has to be really certain that it is iron deficiency anemia before giving parenteral iron therapy. So she is advised all of the following except option number B. Now there is another issue here. The another issue here is that she herself is beta thalassemia trait. Okay, so Vijay Yadav, you are asking, explain option A. She is beta thalassemia trait. Now you see here, Government of India recommendations are, and you would see again, that whenever there is a woman who is anemic, especially when there is low MCV, microcytic hypochromic blood picture, one very important differential diagnosis of iron deficiency anemia is thalassemia, right? So I don't know, those of you who are watching here, you would realize that especially in the North Indian belt where beta thalassemia is a concern, we are routinely screening pregnant women for beta thalassemia. And now in its latest recommendation, which was given by Foxy, just let me mention it here. There's a Mukta scheme that is coming. Yes, right. So this Mukta scheme is regarding thalassemia screening. It is basically for early diagnosis of thalassemia in the fetus. So basically we want to prevent thal major people from being born. That is what that is what it means exactly, because thalassemia major puts a burden on the, it's a burdensome condition, right? So basically that is the concern. So thalassemia screening, latest Foxy is saying that, one should screen all women. One should screen all pregnant women. But understand that screening all pregnant women with the HPLC, high performance liquid chromatography, may not always be possible in all circumstances, considering in the length and breadth of India is, from different resource settings. There are low resource settings, there are good resource settings. So in big cities, people who can afford this, it makes good sense. So again, state-wise recommendations may also be different. But yes, thalassemia latest recommendation is screen all pregnant women with high performance liquid chromatography. But the Government of India recommendation, the national recommendations, they haven't changed as of yet. They do say that one should selectively screen at least those women who are anemic, who have low MCV, who have a blood picture where we can suspect thalassemia, right? Now, the thing is that thalassemia is autosomal recessive, right? Thalassemia is autosomal recessive. So, if the mother is the carrier, if the pregnant woman is the carrier and the father is also carrier, then they can have a child with beta thal major, isn't it, right? So, that is why checking the husband's status is important. Okay, so thalassemia trait is autosomal recessive, and we want to find out if the child is also at risk, or if the pregnancy that she is carrying, the fetus that she is carrying, could be potentially thal major. So that can be known by checking the husband's HPLC status. And if the husband is also trait positive, right, then of course there is a possibility that fetus could be thal major. Then invasive fetal testing will be recommended. So that is why she's counseled about husband HPLC also. She's counseled that in case the husband comes positive, invasive fetal monitoring can be done to know the status of the fetus. And of course, as far as her anemia goes, oral iron and folic acid will be recommended. So this is also, she is counseled. Okay, yes. And Dr. Strange, yes, what kind of invasive fetal testing will depend upon where we are. She is 16 weeks, so for her it would be amniocentesis. But in case this patient would have been picked up at 12 weeks, so anywhere between 11 to 13 weeks, 6 days, then it would have been chorionic villus sampling. So depending on what could have been done at that point in time. Okay, right? So this is about the update also, and this is about the question also. Now, moving on, let's have a look at the next question. Which of the following statements are correct regarding the procedure shown below? Now, the procedure shown below is this. What we are seeing here, a needle being introduced into the amniotic cavity, amniotic fluid being aspirated. The fetal cells that are suspended in the amniotic fluid, they can be extracted, cultured, analyzed for different types of testing, right? So, if cells are cultured, analyzed, we can do karyotype on them. We can go for fetal infections testing on them. We can go for single gene analysis on them. So whatever genetic analysis for which tests are available, those can be done on that sample. That is the whole idea of invasive fetal testing. So which of the following statements are correct? So yes, it can be done between 15 to 20 weeks. True. So this procedure is amniocentesis. Okay. Procedure of choice to diagnose neural tube defects. It can detect fetal anemia. It has the potential of detecting fetal anemia, but it is generally not used for this purpose anymore. So it can detect fetal anemia. That is also true. It cannot be done in Rh negative women. This is a false statement, and it is not a procedure of choice to diagnose neural tube defects. This is also a false statement, right? So if you know this, that it can be done between 15 to 20 weeks of gestation. I'm seeing your answers here. Let's just work out the quick way that we are doing it. We are attempting these questions also, right? So you know that, you know, one option you know for sure to be true, that is option number 1. So you rule out these two options. They are not the answer. Answer would be anything like A or C, right? So you can see here that by eliminating two options you can still come to the answer. So correct answer is option number C. Okay, all right, fine. So yes, now another important point I want to tell you from here is the procedure of choice to diagnose neural tube defects is ultrasound. Targeted sonography is the procedure of choice to diagnose neural tube defects. I have a question on neural tube defects also, later we'll come to that, right? The other point I want to tell you about is that it cannot be done in Rh negative woman is also false statement, okay? Cannot be done in Rh negative women is false statement. If any invasive procedure is indicated in an Rh negative woman, so amniocentesis, this chorionic villus sampling, these are procedures which are done when indicated. They can be done, but in case they need to be done in Rh negative women, then anti-D cover has to be given. Of course, she has to be ICT negative. She has to be not sensitized prior. Okay. So yes, please remember here, for sensitizing events in Rh negative women who is ICT negative, meaning not yet sensitized, anti-D cover has to be given. We call it as routine antenatal anti-D prophylaxis. Okay, anti-D cover has to be given, right? So this is in addition to the routine antenatal anti-D prophylaxis that we give at 28 weeks. Remember this also. Okay, it is separate to that. Okay, so for all Rh negative, ICT negative women, we give routine antenatal anti-D prophylaxis. Remember, at 28 weeks, 300 microgram anti-D IM is given, right? Now, supposing this woman had, supposing she had an abortion earlier, then also it has to be given. Supposing she had an ectopic, then also it had to be given. Supposing she had amnio or CVS planned, then also it had to be given. Okay, and then again at 28 weeks it has to be given. Okay, so routine wala 28 to dena hi dena hai. Apart from that, any other sensitizing event has to be separately covered. Keep that in mind. Okay, now as far as the dose is concerned, ACOG is the only recommendation, ACOG is the only guideline who is saying less than 12 weeks 50 microgram is the dose. Okay, and different international guidelines are mentioning different things. Okay, and different textbooks are also mentioning different things. Now Foxy has said, this is for them from the Indian guidelines. Okay, the Indian guidelines, Foxy has said that any sensitizing event that is happening before 20 weeks, it's 150 microgram. It's 150 microgram, and after 20 weeks it is full dose, that is 300 microgram. Okay, so if they are specifically mentioning ACOG, then you pick 50 microgram, but if they are not mentioning, then before 20 weeks 150 microgram. Okay, so if they are specially mentioning ACOG or American guidelines or something, if they are mentioning, then 50, otherwise Foxy is saying before 20 weeks 150 micrograms. Okay, fine. Yes. So extra pointer update we have covered from this question as well. Now, next question. 30-year-old Gravida 3A2 is seen at 16 weeks. She has history of 2 prior spontaneous pregnancy losses, one at 4 months and the another at 3rd month of gestation. Her history is very typical, first of all. Okay, so that is one suggestion. The other is that she's planned for cervical cerclage procedure. That is your another clue about the diagnosis based on her transvaginal sonography findings. So when you read the stem of the question, I've created the stem of the question in a way that you would revise your topic, okay? So history of recurrent pregnancy losses, or it could have been history of recurrent preterm births also, but each successive pregnancy loss happening at shorter intervals. Cerclage has been planned based on ultrasound findings. So for this patient, ultrasound guided cerclage is being attempted because there are only 2 pregnancy losses, okay? So 1 or 2 pregnancy losses, but with a classical history suggestive of cervical insufficiency. Yes, cervical insufficiency, previously called as cervical incompetence. All of the following are contraindications to the procedure except. Now, what are we seeing in this image? This can be a potential image-based question. So, we are seeing transvaginal sonography. On transvaginal sonography, what is important to make the diagnosis is cervical length measurement. Cervical length measurement, okay, less than 25 mm between 16 to 24 weeks is going to help us make the diagnosis. So when we're measuring the cervical length, can you see here, this is the outline. This is the outline of the cervix, okay. So we're seeing it in sagittal view. This is the internal os. This is the internal os. This is the external os, okay. And what we are seeing here is the closed cervical length. Okay, so we are seeing the closed cervical length, and what you're also seeing here is that the funneling of the internal os has happened. So this is this. Okay, funneling of the internal os is also being appreciated. Funnel may or may not be seen. Funnel may or may not be there. It is what is important is the cervical length measurement. Okay, so what you're seeing here is a Y-shaped cervix, okay. So understand here that when the cervix is opening up, so the internal os is opening up, right. What matters is the closed length of the cervix, okay. So this is a T-shaped cervix, this is a Y-shaped. More of the opening, more of cervical length shortening happens, it becomes a V-shaped cervix, then becomes a U-shaped cervix, like that. Okay, so these are descriptions. What is actually happening is cervical length is shortening. That is what is actually happening. All right. So all of the following are contraindications to the procedure except funneling of internal os is helping us make the diagnosis. It's not a contraindication. So funneling of internal os is not a contraindication. Please remember that. Okay, but yes, of course, if this particular patient was already bleeding, okay, any patient who has bleeding now, she could land up, bleeding is a sign that in no time maybe she will have uterine contractions and she will start with the process of expulsion, and then you don't want to put a foreign stitch on the cervix, right? If she's already having uterine contractions, then also the cervix will eventually open up, and then if you are putting a stitch there, it will tear up the cervix, right? If the membranes are already ruptured, then also in ruptured membrane situations also, if you put a foreign suture there, ascending infection can happen. That risk is there. Also with ruptured membranes, eventually the process of contractions will start eventually, right? So vaginal bleeding, uterine contractions, ruptured membranes, infection already present, and an abnormal fetus. Come to think of it, abnormal fetus, right? What is the whole point of doing a cerclage for an abnormal fetus, probably who has no survival, right? So these are the situations which are actually contraindications. These are all contraindications to the procedure. Keep that in mind. Also remember that ultrasound indicated cerclage, as the scenario in this question has been set up, is usually recommended that it should be done before 24 weeks of gestation. Before 24 weeks of gestation, ideally it should be done. There are situations when we do history indicated cerclage. There are situations where we do history indicated cerclage procedures, and history indicated cerclage procedure meaning that there have been more than or equal to 3 recurrent pregnancy losses and suggestive of cervical insufficiency Then in that case, we don't want to wait for the ultrasound diagnosis. We can do this history indicated cerclage between 12 to 14 weeks of gestation. 12 to 14 weeks of gestation is going to be the ideal timing for such a procedure. This would be the ideal timing. Also remember here that once we put the cerclage, when do we remove it? When to remove? So supposing in this particular patient the cerclage had been put, okay, successful and everything, and then we had to remove it. We have to remove it. When we put a vaginal cerclage, we have to remove it, right? So as and when she, let's say if she when she goes beyond 37 weeks, we remove it, okay. Now earlier also we may remove it if she goes into labor. If she goes into labor, or she has bleeding PV, or she has leaking PV, and membrane rupture happens early on, so we can do it earlier also. So earlier, if she goes into labor, has bleeding, leaking or something, or infection sets in, right? So these are the important pointers that you need to remember. So 37 weeks one need to remove. Once 37 weeks are completed, then you can remove it anytime. Okay? Clear? Now, let's have a look at the next question. A 32-year-old woman who has been a known diabetic for many years presents with history of missed period. She has a positive pregnancy test. She is anxious or she is concerned about the risk of diabetes adversely affecting her baby. Now, which of the following would be the most helpful investigation to identify the risk of fetal malformation in this woman? So, risk of fetal malformation they are talking about. Look at the context. She has come in early pregnancy. She's just tested UPT positive. Okay. So, please look at the context also for those of you who are choosing option D, C, B, those of you who have picked up those options. They're talking about the risk of fetal malformation, gross congenital malformations, right? So, to know the risk right now, best would be glycosylated hemoglobin, HbA1c. Okay, HbA1c is going to point towards the degree of glycemic control. Okay, so you do it right now, it gives you an idea about the degree of glycemic control in the preceding 3 months. So it will give us an idea about the periconceptional HbA1c levels, right? So higher the HbA1c levels, higher is the risk of fetal malformation. So ideally this should be less than 6.5%, less than 6.5%, right? Now, targeted sonography is for detection of fetal malformations, right? So, women who are, so targeted sonography will be done, level 2 scan is done as anyways as a routine in pregnant women for detection of fetal anomaly, not defining the risk or not identifying the risk, but actually picking up these fetal malformations. So targeted sonography is not the answer. Now, first trimester combined screening, all of these testing, first trimester combined screening, first trimester we earlier used to do the dual test, but dual test we don't do isolated dual test anymore. We combine it with anti-nuchal translucency, and then we do the first trimester combined screening, or you have the quadruple testing, or you have the triple testing, or you have the NIPT and everything. These are prenatal aneuploidy screening tests. They give you the risk assessment of aneuploidies, not of gross congenital fetal malformations. Okay, so this is not the answer. However, in this patient also, anyways, when she will be at that point in time in first trimester, we will counsel her to get a first trimester combined screening to be done. And And on top of that also, please remember that these prenatal aneuploidy testings are routinely counseled to all pregnant women. All pregnant women routinely, doesn't matter their age, they are offered these aneuploidy screening tests. Keep that in mind. Now, fetal echo. Fetal echo is again going to analyze for fetal cardiac malformations, right? So, yes, when a diabetic woman is pregnant, particularly non-diabetic woman, okay, non-diabetic woman is pregnant, particularly if the sugar levels are deranged, we want to go for fetal echo also as a part of their antenatal workup. And there are times when on routine scans in routine pregnancies, when we go for targeted sonography, level 2 ultrasound shows some suspicion of cardiac malformation. Then also we can go for fetal echo, right? So if there is suspicion of cardiac malformation, if there is a high risk situation where cardiac malformations are more likely, then fetal echo would be justified in the antenatal period, right? And fetal echo is done between 22 to 24 weeks, and targeted sonography is done between 18 to 20 weeks. Okay. Right. So the correct answer to this question becomes HbA1c. All right. Now also now Shubhi, you are asking, investigation of choice for congenital malformation is level 2 scan, target scan. See, level 2 scan is like the common language, okay? वो level 2 बोलते हैं, but it is actually a targeted scan only for fetal anomalies, okay? Okay, the one that is done at 18 to 20 weeks, that is level 2 scan only, targeted sonography only, okay? And yes, fetal anomalies, they are expected with pre-gestational diabetes, not with plain GDM, not with gestational diabetes mellitus. Yes, you are right in that as well. And also remember one more thing. Ideally, such patients should be getting, ideally these patients with overt diabetes mellitus, they should be getting preconceptional counseling. They should be getting preconceptional counseling. Okay. So, when we are giving them preconceptional counseling, they should be told that first they should control their blood sugar levels. Okay. And then they should think about getting pregnant, and then they should start trying for pregnancies. Okay. So preconceptional counseling, control the HbA1c, control the blood sugars, and ideally one should switch them over to safer insulin, right? Ideally switch over to insulin. Okay. Now, fetal macrosomia by itself is not going to be an indication for a direct LSCS, right? When we talk about macrosomia, when we talk about big baby or large for gestational age, okay, then when there is a diabetic woman with a large for gestational age fetus, if the estimated fetal weight is more than 4.5 kg, and in a non-diabetic woman, if the estimated fetal weight is more than 5 kg, then we offer elective cesarean section. It's not like an absolute indication. We offer to the woman, then she will decide whether or not she agrees. But yes, we have to decide based on estimated fetal weight. Okay. Now, next question. A low-risk primary at term is admitted to the labor room. On per abdomen examination, the uterus is term size, cephalic with head 3/5 palpable above the pelvic brim. See, when you have these such long read questions, okay, when we are talking about progress of labor like questions or clinical questions, it's a good idea to read the first line. So, low risk primary admitted to labor room, and they're giving you findings. Stop there, okay? Context has been set. Progress of labor like question. What should be done next? Look at the 4 options. What 4 options do you have to choose from? Oxytocin, ARM, waiting and watching, and cesarean section. Okay. So these are the 4 options on from which you have to choose from. Okay. And then you read the question again, so that you know that for these particular options, you have to look at keywords. You will answer mostly clinical questions by eliminating at least 2 options. That is going to be your priority first. Okay. Now, Shivi Jain, if there is a cardiac congenital anomaly on scan, abortion done. Yes, abortion can be offered if there is a gross congenital anomaly incompatible with fetal life. So again, that will depend. There are different kind of congenital heart diseases. ASD, for example, a congenital heart disease is very much treatable postnatal by surgical management. But supposing you get a gross congenital anomaly in which let's say a hypoplastic left heart syndrome, then a decision may be taken. So such decisions, abortion is allowed by law in cases of gross congenital fetal malformations, which are significantly going to affect the fetal newborn survival or may lead to permanent handicap. So those are the recommendations. Okay. So yes, it is potentially allowed. So yes, so term size, cephalic, head 3/5 palpable above the brim. 3/5 palpable above the brim, I would say it is not engaged right now. One, fetal heart rate is okay. Fetal heart rate is localized to the right flank, getting 3 contractions in 10 minutes, each lasting for 20 to 30 seconds. So mild contraction. So far, so good. Cervix is 4 centimeter, 50% effaced, loose hanging bag of membranes. Sagittal suture obliquely placed. Anterior fontanelle felt on the maternal left towards the pubic symphysis. This question they could have asked you, what is the position? If they had asked you what is the position, this is ROP position. Okay, this is ROP position. All right, this is ROP position. So what would be done next now? And whatever the position would have been, the management would not have changed. Whatever the position would have been, management would not have changed. She is still in early labor, she's in latent phase, she's not yet reached active labor. So oxytocin infusion right now is not needed. Okay, oxytocin infusion right now is not needed. She's only 4 centimeter, right? Over a period of time, if labor progress is slow, then oxytocin may be needed. ARM right now not needed. So ARM, oxytocin, these are all done when the progress of labor is slow in active phase of labor. Not right now. Right now, management is wait and watch for spontaneous progress. So even in ROP position, most of the time favorable anterior rotation of the head will take place. Favorable anterior rotation will happen majority of the time in ROP position. Okay, and for anterior rotation to happen, we need good contractions, we need favorable shape and size of the pelvis, right? An average size baby. So she is a low risk primary anyway. So we are expecting that progress will happen. So that is what we are going to do. Wait and watch for spontaneous progress of labor, and cesarean section is definitely not recommended now. So doctor, okay. So what about the loose hanging bag of membranes? So if there is a loose hanging bag of membranes, generally there is a tense bulging bag of membranes. The bag of membranes is tense and bulging when the fetal head is well flexed and it is well fitting into the lower uterine segment. Okay, with a well flexed head, the head fits well into the lower uterine segment. There is a tense bag of membrane, tense bulging bag of membranes, right? Now with ROP position, we can expect the head to be deflexed, and that can cause the bag of membranes to be loose and hanging and not tense and bulging, okay? And that is why in ROP position, generally early spontaneous rupture of membranes may also take place. That doesn't mean that we should go for artificial rupture of membranes. No, why should we rupture membranes? Otherwise, you will put the patient in a situation where she'll spend a longer duration of her labor with absent membranes, and that increases the risk of infection. It is an unnecessary intervention if it is an unnecessary intervention if we rupture the bag of membranes right now. Okay, so that would be unnecessary. Okay, fine. And position Position. How do we identify the position here? So see here, the fetal heart rate is localized best in a position, best radiating from the backside. Okay, so wherever the backside is, wherever the fetal backside will be, that is where you will best localize the fetal heart rate. So here towards the right flank, that is your biggest clue. In occipito-anterior positions, the fetal heart rate is more anteriorly placed on the abdomen, not in the flanks. That's one clue. And the other important clue here, we see when we do the PV examination. When we do the PV examination, just think about it. Imagine a woman lying in front of you, right? So this is the pubic symphysis. This is the sacrum. This is how you're going to analyze, okay? And they have mentioned it in they have mentioned it, described the findings. They may give you image also. But yes, what were the findings? The findings were that the sagittal suture is obliquely placed. So sagittal suture is obliquely placed and the anterior fontanelle. This is the anterior fontanelle quadrangular. It is on the left side. This is left side of the mother. This is the left side of the mother. And the posterior if the anterior fontanelle is on the left side, definitely the posterior fontanelle is opposite to it. This is the sagittal suture obliquely placed. This is what the question is describing. And that is how I know that this is occiput. See, occiput. Where is the occiput? Occiput is the denominator for cephalic or for vertex presentations, right? So this is on the right side of the mother. Right occipito posterior. Okay, this is anterior, this is posterior, this is right occipito posterior. Okay, like that. And similarly, if it would have been like this, anterior fontanelle on the left side, posterior fontanelle here, sagittal suture transversely placed, that would have been right occipito transverse. This would have been right occipito transverse. So you get the idea about the position. You get the idea about the position, okay, right? Okay, so this is left side of the mother, right side of the mother. Okay, so this is triangular fontanelle, right occipito transverse, sagittal suture transversely placed. This is how you would get the idea. Next question. A low-risk primary at term was admitted in active labor in cephalic presentation. The most appropriate next step they are asking, okay? And she has been in second. See, Pratyusha, our left is right. Why not left? Why not left? Because occiput is on the left. Okay, Ashwini? Ashwini? Right, so you really need your basics stronger for attempting clinical question like this. So if you are having difficulty with finding out the positions like this, then you need to just go through at least the rapid revision videos where we are talking about the identification of different positions. Okay, this is very, very important. So occiput is the denominator, that where the denominator is situated defines the position. All right, so one clue I have given you in the question, keyword flank पे है कि anteriorly placed है, and then occiput किधर है. When the vertex presentation is there, look at where the occiput is. Okay, so that will tell you. And why not left, I have told you. Now, our left patient right, I know undergraduate students में ऐसा होता है. Please remember, whenever we say left and right, it is always in reference to the patient, not just in obstetrics. Okay, any medical examination, surgical examination, left and right are always in reference to the patient, not just in obstetrics. Okay, coming to this question, What is the most appropriate next step? Ventouse outlet, mid cavity, low forceps. Mid cavity forceps will never be the answer because we are not doing mid cavity forceps. Okay. Low risk primary in active labor. She's been in second stage for 2 hours. There's fetal bradycardia. She's getting 4 contractions in 10 minutes, each lasting for 50 seconds. So she is getting good contractions. The station is +3. Sutures are in AP diameter. So it's a rotated head. When we say sutures are in AP diameter, meaning it is occipito-anterior or occipito-posterior. AP diameter would be this. Sutures in AP diameter would mean this. Like this. It is a rotated head. It may be occipito-anterior, it may be occipito-posterior. That information is not given in the question right now, and it doesn't matter. It doesn't matter also. It is a rotated head. There is caput, but there is no molding. So there is no CPD. At least we can be saying that there is no CPD. What is the most appropriate next step? Very good. It is outlet. Caput, so no vacuum, bache. Ahmed, caput is there. There is a caput, and with caput, ventouse would not be very ideal. It's not like ventouse cannot be used. Supposing if I were in this position and I don't know how to use forceps. I'm not very comfortable. I'm not very confident with forceps. I can choose vacuum also. It's not like it's contraindicated. But assuming that I know everything, okay, and assuming that I'm confident in both, then the best answer to choose would be outlet forceps. Okay, so aspire for the moon, why not it? Just because of caput. Just because of caput. Okay, so when there is the caput, you see forceps are more grasping on the baby's scalp. Okay, when we put, there's a huge caput here, that's, let's supposing, and you're putting a vacuum, the fitting and the suction becomes problematic with the caput. It can pop off, it can, so that's why. So forceps, outlet forceps, better answer. And outlet forces because head +3 station. When they're saying head +3 station, it itself is pointing that the head is at the perineum. The head is at the perineum. Okay, and it has reached the pelvic floor. That is what +3 station in short means. Low forceps will be at +2 station. Okay, so yes, Sitinder, it's not like vacuum is contraindicated or anything. One could use, but they're asking you most appropriate, so better to choose outlet forceps as the answer. All right. Now, next question. Look at this question. Again, they're asking you most appropriate management. Now, this time you have oxytocin, instrumental delivery also, and urgent cesarean also. She is G2P1L1, previous cesarean section at term, active labor. Her pulse rate is slightly, there's tachycardia, but the BP is fine. She's getting good contractions. Baseline fetal heart rate 120 beats per minute with persistent late decelerations. PV shows that the cervix is fully dilated, fully phased, vertex at +1 station. Sutures, LOA, fine. It's almost a rotated head. LOA means 45 degrees short of rotation. Look at this. LOA. If it is LOA like this, it is just 45 degrees short of rotation, not completely rotated. Membranes absent like a meconium stain. Which of the following is the most appropriate management? You see, sometimes when you have long read questions, one or two keywords. Please understand, one or two keywords are enough to come to an answer in long read questions. Okay, you don't need the entire context is set for you, that's another matter. But to attempt answers correctly, you need one or two punching keywords. Like here, there is fetal distress, yes, of course, and vertex is at +1 station. So with the fetal distress, previous cesarean, I want to deliver. Okay, that decision has been made. Now, she's already getting good contractions, so oxytocin is not needed right now. And at +1 station, +2 station and beyond is needed. +2 station and beyond should be there for instrumental vaginal delivery. So, these are anyways out. These are anyways out. So I want to go for an urgent cesarean section. I want to go for an urgent cesarean section because we are going for instrumental vaginal delivery. Only and only all the criteria are fulfilled, and one of the key important criteria is that the station is +2 and beyond. +2 and beyond. Now, Pratyush, please don't remember this line that fetal distress means always LSCS. No, fetal distress doesn't always mean LSCS. In the previous question, you had fetal bradycardia. Okay, but the quickest way to deliver right now was to quickly apply outlet forceps and deliver. So fetal distress means I have to deliver quickly. That's right, right? Now quickly by whatever means. Patient is there on the table, criteria for instrumental delivery is fulfilled, we can go for instrumental delivery, right? If you want to prep her up, if in this question the criteria of instrumental delivery was not fulfilled, then I would have got no other choice but to, you know, quickly mobilize her to AT and take her up for an emergency cesarean section. So please don't remember that line that fetal distress means always cesarean section. Keep that in mind. Here in this situation, instrument delivery cannot be done and I have to expedite delivery. Therefore, urgent cesarean section. Now, similarly, meconium stained always cesarean section. Please don't remember this statement also. Meconium stained always cesarean section is not a correct statement. Alright. Meconium stained liquor means that one needs to go for at least continuous cardiotocography monitoring in labor, and just on the basis of meconium alone decisions for cesarean section are not made. That is a wrong thing to remember. All right, yes, in clinical practice sometimes we do take that decision. Sometimes patient is far away from delivery, maybe in early labor, cervical findings are not very good and there is thick meconium. One may choose cesarean section in that situation, but it is not always cesarean section. Keep that in mind also. Okay, clear? Now, next question. Which of the following statements regarding variable decelerations is false? Which of the following statements regarding variable decelerations is false? Yes, they're abrupt and erratic. There is, see, deceleration in itself means that there is decrease in fetal heart rate at least more than 15 beats per minute, lasting for at least 15 seconds and less than 2 minutes in duration. If a deceleration, if a drop in fetal heart rate happens which is going to keep persisting for more than 2 minutes, it's a prolonged deceleration. Okay, so this is true. This is true. Bache, B option is true. If you look at the images, just look at the images of deceleration. Okay, just look at the images of deceleration. The fetal heart rate drops. The fetal heart rate, this is the baseline fetal heart rate. There is a drop and then it comes back. No, that is deceleration. Just the exact opposite of acceleration. If it is going to keep persisting, if there is a drop that happens, if there is a fetal heart rate drop that happens and that keeps persisting and then keeps persisting, it's a prolonged deceleration. Okay, keeps persisting beyond 2 minutes, it is a prolonged deceleration. But less than 10 minutes. Okay, if there is a deceleration that happens, that it stays at that level beyond 10 minutes, then it's a baseline change. If a drop happened and then it is persisting beyond 10 minutes, then it is a baseline change. Then it is a baseline change. Okay, then it is a baseline change, then it is a bradycardia. Then it is a bradycardia. So a deceleration in itself means that it dropped and then came back. Okay, fine. So keep that in mind. Now coming to the question again. So option B is true statement. Okay, now they are abrupt and erratic, that is also true. Okay, they are abrupt and erratic, that is also true. They can be followed by an acceleration, that is also true. And most of you have answered this correctly. They are not seen with uterine contractions is the false statement. Is the false statement. They can come. Variable decelerations are unrelated to uterine contractions. Unrelated meaning they can come with contraction, without contractions, before contraction, after contraction. So that sort of relation with contractions is not there. If you recall, variable decelerations are happening because of cord compressions, because of cord compression. And you can now also understand that it is quite possible that variable deceleration can happen with contraction, because it is during uterine contractions that the chances of cord compression may also increase. Okay, so it's not seen with uterine contractions, it's false. It's not related to uterine contractions the way early and late decelerations are typically related to uterine contraction. So it can come with contraction, on top of contraction, before contraction, after contraction, without contraction. That is what variable decelerations are. And yes, they can be seen spontaneously as well. Yes, Dr. Anubhav, they can be seen spontaneously as well. So if you look at these variable decelerations, okay, they are not related to contractions. They are because of cord compression. And abrupt and erratic means, see, if many times students ask me how do we differentiate between variable and late. So if you look at this one here, these are early decelerations, exact mirror image of the contraction. This is the contraction, this is the drop in fetal heart rate, right? They are happening because of fetal head compression. They are happening because of fetal head compression. Okay, if you look at late deceleration, this is the contraction, and the drop in fetal heart rate is happening once the contraction has already started. So there is a delay in start of the drop of fetal heart rate. Okay, and you can see that by the time the contraction is over, the fetal heart rate has still not normalized. So it will take some time to get back to the baseline also. So it is slightly late as compared to the contraction. That is what it means. Okay, now please remember here that late decelerations are associated with fetal hypoxia and uteroplacental insufficiency. For INI-CET level, you should know, they have asked in the past, they have asked mainly about early decelerations, that these are basically vagal stimulated. They are because of vagal stimulation in the fetus. So when the head compression occurs, the fetus vagus nerve gets stimulated, vagal stimulation happens, and that leads to a drop in fetal heart rate with contraction. And once the contraction is over, head compression is over, and vagal stimulation is over, fetal heart rate has normalized, right? Now with fetal hypoxia and uteroplacental insufficiency, what is happening? That, come to think of it, when we will have hypoxemia, one thing is hypoxia, the other is hypoxemia, low oxygen tension in the blood. So our body's chemoreceptors are also going to detect that, and our heart rate will also drop. That is what is happening here also. So these are chemoreceptor mediated reflexes, chemoreceptor mediated drop. Okay, so that is why it takes some time for the oxygen tension to fall to that level, that which can trigger this drop in fetal heart rate. So that is why they are slightly delayed, that is why they are late. These are chemoreceptor mediated reflex drops, right? And if you look at variable decelerations, they are abrupt. See, the time taken for this to reach here from the baseline to the lowest point, it is smooth transition. It's like a cup. See, it's like a cup. It is smooth. It's time. It takes time. So it takes about 30 seconds. It takes about at least 30 seconds. Okay. Nobody is going to ask you to measure the time. The thing is that it will look like a cup. But variable deceleration quickly drops. Quickly drops. The abrupt and erratic, that is what it means. It quickly drops from the baseline here to the lowest point. It reaches in less than 30 seconds. It reaches in less than 30 seconds from here to here. That is why I say abrupt and erratic. Abrupt and erratic. Okay, fine. And these are baroreceptor mediated. These are baroreceptor mediated, right? So when umbilical cord compression happens, the blood flows to the fetus. They are affected. They cause blood pressure changes. In response to those blood pressure changes, fetal heart rate drops abruptly. So that is the thing, right? And very important point, concerning features about variable decelerations are, if they are associated with absent beat to beat variability, no shoulders, depth means the drop is more than 60 per minute or lasting more than 60 seconds. These are concerning features for variable deceleration, right? So you can see here, this is one shoulder, this is another shoulder. So there is a drop, variable deceleration. This is shoulder followed by acceleration. So see, you can see here it is preceded by acceleration and followed by acceleration. These are shoulders. These are shoulders. Okay. No shoulders. Sometimes we have variable deceleration like this. No shoulders. Sometimes we have variable deceleration like this. If there are no shoulders, then it is a concerning feature. Okay. Now, let's have a look at the next question. A 32-year-old primary gravida is seen for routine antenatal visit at 12 weeks of gestation. She is obese. She has conceived with IVF. And based on her high risk profile, she is being advised an ultrasound Doppler. Which of the following Doppler parameters help in predicting her risk of preeclampsia? So I have framed this new question basically to discuss an update with you regarding screening for preeclampsia. This update had been there for quite some time. You know, the international recommendations, the FIGO had given it way back, okay, 3-4 years ago, but now recently FOXI has also adopted them. So that is something new regarding screening for preeclampsia. So in my lectures, I used to teach the FIGO also earlier, but this has now been accepted by FOXI also. So yes, uterine artery pulsatility index more than 95th centile. So excellent everybody who is attempting this question correctly. So she must have been advised a uterine artery Doppler. And uterine artery Doppler, between uterine artery Doppler, we have to check the pulsatility index in both the arteries. So we have to check the mean pulsatility index between 11 to 14 weeks, okay, and this will be predictive of preeclampsia. Not 100% predictive, no test is 100% predictive, but yes, predictive of preeclampsia, especially early onset preeclampsia. Early onset preeclampsia is the one that develops before 34 weeks of gestation. Early onset preeclampsia is the one that develops before 34 weeks of gestation. Okay. So recently FOXI came up with the update regarding screening for preeclampsia. Okay. Now, this is something that is not new. All women are screened for preeclampsia. How you screen is another matter. In every visit in the antenatal OPD, we take history of evolving risk factors. We check the weight, we check the blood pressure, we take the history of the patient. So, every time we do it, we have been doing it forever. Okay, the risk factor based screening. Okay, so all women are anyway screened. Now they are saying that one should screen with multimodality screening as well. One should do with multimodality screening as well. So this is a gestosis score that has been devised in India itself. Okay. Now again, this gestosis score is risk factor based. There are numerous risk factors which are listed in the scoring system. Different risk factors are given a score of 1 or 2 or 3. And based on those risk factors, if your combined score is more than or equal to 3, woman is considered at risk. Okay, this is risk factor based, know this much. And then there is a multimodal screening. This multimodal screening by Foxy has actually been adopted from what Figo has mentioned earlier. So this is 11 to 14 weeks it should be done. Okay, and this will contain the same thing. It will contain the risk factor base profile, it will contain mean arterial pressure, it would contain the uterine artery Doppler, and it would contain the serum placental growth factor levels also, and we will feed it into a computer system and everything, and that will give us the combined screening result, right? So this is multimodal screening. The limitation with multimodal screening will be it will need resources, no, right? So like Doppler के लिए she will have to be sent for a radiologist. This she will have to pay out of her own pocket for serum placental growth factor. So yes, it will be resource intensive, and risk factor based scoring they are also mentioning. Now for prevention, so you will do a screening for a thing only and only if you have a preventive strategy in place. Now the most accepted preventive strategy for preeclampsia is aspirin. Aspirin is the most accepted preventive strategy, and there has been a long debate about the dose also, right? So when Foxy is saying now 70, if somebody is testing positive by the gestosis score, then 75 milligram per day has to be given. I mean, this is the minimum dose that has to be given, right? And for somebody who's testing positive by the multimodal screening, they are saying for these women can give up to 150 milligram per day, can give up to 150 milligram per day, and they have left it to the prerogative of they have left it to the clinician. Okay, so generally, like for example, when we have obese women with larger body surface area, multiple risk factors are there, multimodal screening may be positive, then one thinks about at least giving up to 150 milligram per day. Otherwise, yes, baseline 75 milligram to minimum dena hi dena hai as far as the dose of aspirin is concerned, right? So dose can be 75, dose can be 150, and another important thing is which is more important for undergraduate student is when to start. So the reason that we are going for this early screening is so that we can start as soon as possible, start ASAP, preferably before 16 weeks. So it's not like you have to start at 16 weeks, okay? No. You start as soon as possible. Ideally, it should be started before 16 weeks. Sometimes some benefit is there even if one starts up till 18 weeks or something. So start as soon as possible, preferably before 16 weeks. And once it is started, it has to be continued till at least 36 weeks, till at least 36 weeks. So remember these new things about the preeclampsia screening as well. And You're asking what is option A in question. Option A in question is umbilical artery pulsatility index, right? So umbilical artery Dopplers, they are the first line Dopplers when you evaluate a growth restricted fetus. That is where umbilical artery Dopplers are used, not for predicting the risk of preeclampsia. For that it is not used. MCA-PSV Doppler is for early detection of fetal anemia. So umbilical artery Dopplers are for evaluation of fetal growth restriction. MCA Doppler is for early detection of fetal anemia. So you had to choose between B and C actually in this question. Okay. Now, let's have a look at the next question. Primary gravida is admitted at 34 weeks of gestation complaining of leaking PV for past 4 days. Her pulse rate is 110. BP is 110 by 70. So tachycardia is there, history of leaking PV for 4 days. She is preterm. This is PPROM. Okay. Temperature 102. Per abdomen, symphysis-fundal height is less. Uterus feels tender. FSH is 160. Fetal tachycardia. Per speculum, foul-smelling vaginal discharge. Os is closed and the cervix is long. Ultrasound shows a single live fetus, absent like a fundal placenta. So she has history of prolonged leaking now. For 4 days she has been leaking. She is not yet in labor. Uterus feels tender. All of these findings are pointing towards chorioamnionitis. All of these findings are pointing towards chorioamnionitis. Now this is not just PPROM. This is not just PPROM, this is PPROM that has gotten complicated now with chorioamnionitis. Baseline investigations are sent. Now there is no point in continuing the pregnancy at all. Even without chorioamnionitis, once 34 weeks are crossed, most of us are going to go for, induction of labor and delivery with PPROM. Once 34 weeks are crossed, preference is given to delivering. अगर यही चीज term पे हुई होती, if PPROM and leaking would have happened, patient was not in labor, she was already term, no doubt one would go for delivery. Okay, so now at 34 weeks, giving steroids not needed. Anyways, chorioamnitis is a contraindication for steroids. Anyway, she is 34 weeks completed, no steroids, no tocolysis also. There is no point in tocolysis because I want her to deliver. So that's why no tocolysis, right? Give antibiotics, yes, but give antibiotics and at the same time start with induction of labor, make her deliver, right? So once you read through the question, once you see chorioamnitis like picture, you know that we have to deliver her. So once you know that you have to deliver her and with chorioamnitis, your answer becomes give antibiotics and induction of labor, and the rest of the options are not the answer. Okay, and yes, vaginal delivery is going to be preferable under most circumstances until unless there is an obstetric indication, right? So here vaginal delivery can definitely be attempted. Next question. You are delivering a multiparous woman in LR. Baby delivers uneventfully. You follow AMTSL protocol like you are supposed to do. You encounter delivery in delivering the placenta. In another 10 minutes, you realize that the placenta has not separated and complete uterine inversion occurs. Her heart rate is 60, BP is 80 by 42. What is the best course of action? Yes. So Pratyush very quickly answered, manual reposition of placenta ideally should be done in the OT, and all of you are answering that question, right? So in this situation when there is uterine inversion that has occurred, right, the initial shock is neurogenic. So she may not be bleeding very heavy initially. Ultimately, yes, hemorrhagic shock will happen, but the initial shock is neurogenic. Okay, however, one of the important risk factors for uterine inversion is also morbidly adherent placenta, right? So if we try to remove the placenta, by bits and pieces, and if it is morbidly adherent, then she will bleed even more, right? So do not immediately attempt to remove the placenta, that is wrong, right? And manual reposition in the labor room, Ideally, no. Ideally, no. And manual reposition of placenta in the OT is the best choice to do. Oxytocin infusion right now, when there is no PPH happening, maybe is going to worsen the situation. Why? Because it is going to make the, it is going to, we have to reposition. So when we have to reposition, uterus needs to be relaxed. When we have to reposition, uterus needs to be relaxed. And that is why I want to do it ideally in the OT under anesthesia, under antibiotic cover. And when I give anesthesia, anesthesia may be good enough to relax the uterus. The uterus may naturally be relaxed because uterine inversion has happened. Inversion uterus, the biggest risk factor is, the most important risk factor for inversion uterus is atonic uterus actually. Atonic uterus, right? So it's not difficult to achieve this relaxed relaxed uterus state. So anesthesia by itself could also help relax the status. Sometimes anesthesia is not adequate to relax the status, then we may need tocolysis, plus minus tocolysis. Acute tocolysis may be needed in this situation sometimes, not always needed, right? So because I want to go for manual reposition, for that I want the uterus relaxed. So in the absence of PPH, I will not be starting an oxytocin infusion. So that is not the best choice answer to do. The best course of action would be to inform the serial, to mobilize the teams and attempt manual removal with placenta in situ in the OT itself. Okay, so that is your best choice answer. Manual reposition method is called as the Johnson's method. Okay. In labor room, complications risk present, that is why not done. In labor room, the biggest reason it is not done in labor room is because it requires anesthesia. Okay. It is ideally done under anesthesia. The thing is that one would attempt in the labor room first, then fail at it, and then mobilize to the OT and waste time, right? So that is why ideal circumstances it would be attempted in the OT. There have been times, and I don't know if you've seen, sometimes we have manually repositioned in the labor room also, provided that that you are the person who is delivering the baby, and immediately when you delivered, the uterus was relaxed also, and you took that opportunity to go for manual repositioning, right? But most of the times undergraduates will not be in this position. Okay, so it's not like in the LR it cannot be attempted at all, but it is obviously ideal circumstance it would be to mobilize an OT and then take her up. Okay. Next question. G2P1L1 woman with history of previous cesarean section delivered vaginally. While delivering the placenta, the umbilical cord gets avulsed and the patient starts to bleed profusely. What would be the best course of action? So she is in the third stage. While delivering the placenta, umbilical cord gets avulsed. Okay, so maybe you're trying to deliver the placenta by control cord traction. Umbilical cord is in your hand now. Placenta is still inside. So this is retained placenta. This is retained placenta now. And what is happening right now is she's starting to bleed profusely. Now, in the face of retained placenta, if bleeding is happening, if PPH is happening, you mobilize. Okay, you mobilize for manual removal of placenta in the OT. Okay, best course of action, right? Oxytocin infusion you can start. She's having PPH, she's bleeding profusely. You can start with the oxytocin infusion. If it was a multiple choice answer, then oxytocin we will start because she's having PPH. If this question was multiple options correct, then oxytocin infusion you will also start. Okay, oxytocin infusion you will also start because she has started to bleed profusely. Massage you will also do. Maybe the uterus is atonic and that is why it is a retained placenta. Right. So massaging uterus is also you will also do. This also you will do. So if multiple choice answer was there, then obviously all of this would make sense. Massaging the initial protocol that one follows in PPH, that initial protocol will have to be followed. Okay, control cord traction तो आप कर ही नहीं सकते, cord is in your hand now. right? Cord is in your hand, it is a valve. Control contraction you can't do, right? So best course of action, best answer to choose is manual removal of placenta in the OT. Single best answer would be option number D, right? Now latest WHO has also updated its recommendations on retained placenta. About the duration, one can wait before attempting manual removal of placenta. So let's say here we had delivery of the baby happened, and then we have waited for 15 minutes and placenta has not delivered. We will call it as now retained placenta. Okay. Now understand here where the context is coming from. 15 minutes. See, we routinely follow active management of third stage of labor. So when we have delivered the baby, immediately after delivery of the baby, we have already given a uterotonic. We have already we have done the delayed cord clamping. We have already spent some time in the third stage. And because we have already given a uterotonic in the third stage, after delivery of the baby for AMTSL, I am expecting that within the next 5 to 15 minutes, placenta should be delivered. And I will try to deliver the placenta by controlled contraction. So 15 minutes. 15 minutes I have spent, placenta not delivered, it is retained placenta, right? And after that, if there is no PPH, one can still wait for another 15 minutes. If no PPH, one can still wait for another 15 minutes before intervening, okay? Before moving on to manual removal of placenta. Meanwhile, one can try meanwhile controlled contraction. One can try to empty the bladder. Okay, so 15 minutes more one can wait. Pehle 30 tha. Now it is 15. Okay, 15 minutes to call retained, can wait for another 15 minutes in the absence of PPH before proceeding to manual removal of placenta. But if obviously there is bleeding, if PPH is there, okay, in case PPH is already there, if patient is already under anesthesia, okay, then one needs to go for manual removal of placenta. One should mobilize for manual removal of placenta, simultaneously initiating the early steps of PPH management as well. And if you're thinking of giving uterotonics for PPH, if one is thinking of giving uterotonics for PPH in this situation with retained placenta, this is all retained placenta. In this situation of retained placenta, if PPH is happening, please mark avoid methergin and avoid injectable prostaglandins. So oxytocin one can give. Safest oxytocin one can give. But avoid, so oxytocin remains. What only remains in oxytocin? Methergin don't give. Injectable prostaglandins are not recommended here in this situation also. So those are you cannot give. Okay, clear? Carboprost cannot be used. No. Injectable prostaglandin, no carboprost. There is a injectable PGE2 also, sulprostone. No injectable formulations of prostaglandins, and no methergin oxytocin combination also. No centrometrin also. Oxytocin would be the safest bet. Oxytocin. Okay. Fine. So this is about retained placenta. All right. Now, there are certain important images about morbidly adherent placenta that I want to show to you. Okay. So, when you talk about placenta accreta syndrome, morbidly adherent placenta, increta can be there, percreta can be there, accreta can be there. Okay. Please remember the key important pointers regarding placenta accreta, increta, percreta. This is just to give you a perspective of what this is. This is morbidly adherent placenta. Okay, this is just to give you a perspective. When there is a morbidly adherent placenta, it could be a surprise diagnosis. It could be a surprise diagnosis because of retained placenta. Okay, we ended up with a retained placenta like situation. Think, okay, the placenta is morbidly adherent, so it will not separate either at all, or the placenta will separate in bits and pieces. If the placenta doesn't separate at all, bleeding risk isn't there. If the placenta separates in bits and pieces, the risk of bleeding with retained placenta, with morbidly adherent placenta, ending up with a retained placenta, is because of a placenta that separates in bits and pieces, and if the uterus tends to remain atonic. These are the two reasons why the patient would bleed. Okay, placenta separating in bits and pieces and uterus remaining atonic. Okay. So one could end up in a retained placenta like situation. One could end up with a uterine inversion like situation with the morbidly adherent placenta, right? So it is very important that we have an antenatal diagnosis of morbidly adherent placenta. Okay, so when we have an antenatal diagnosis, most of the times our initial investigation of choice is an ultrasound Doppler. Ultrasound Doppler is the initial investigation of choice. Okay, so in women who are previous cesarean section, particularly in women who are previous cesarean section and in this pregnancy they have a placenta previa. History of previous cesarean section, this pregnancy placenta previa, for the maximum risk of having morbidly adherent placenta. Okay, so initial investigation of choice is ultrasound Doppler. You can see here that this is the placenta, and there are placental lakes and lacuna, these empty spaces, placental lakes and lacuna. And if we were putting Doppler inside, Doppler we would use, then we would find that placental lakes and lacuna, they're having turbulent flow. And this is the bladder in front. This is the bladder in front. This is the placenta. This is the baby's part. Okay. So this is the bladder in front. This is the placenta, and we can see all this vascularity in the bladder serosa interface. We can see this vascularity in the bladder serosa interface. So that also helps in making the diagnosis, right? And yes, otherwise we will go for MRI. If this is the next investigation, if this is inconclusive, or we want to go for surgical planning, meaning MRI will be needed as and when necessary. Okay, supposing one wants to see that is it perforating the bladder also, is it percreta, right? Then one needs to, is it perforating adjacent organs? Because then surgical planning would be needed. Then I will not open up the patient by myself. I need a urosurgeon also with me. Or if it is perforating into nearby gut, I need the GI surgeon with me for this particular patient. So multidisciplinary approach, isn't it? So MRI, yes, is surgical planning. And once you have the antenatal diagnosis, then ideally it has to be managed by a multidisciplinary team in a tertiary care center, and elective cesarean section is done anytime between 34 to 37 weeks. Anytime between 34 to 37 weeks, elective cesarean section is done. Placenta is left in situ and proceed to hysterectomy. This is the standard of care. Okay, instead of landing up with an emergency hysterectomy, this is what the standard of care is. Sometimes patients are very keen of preserving their uterus and wanting to conceive in the future. Then there are other options available, like not proceeding to a hysterectomy for one and leaving the placenta in situ and letting the placenta getting dissolved on its own. It's also a very risky and approach. So that is why this is the standard of care. At least remember this much and look at these images. So this is the cesarean image. You see, we opened up the abdomen, and it is not perforating the serosa. It is reaching all the way up to the serosa, this placenta. And if you can see here, when we were delivering the baby, we gave an incision on the upper segment. We gave an incision away from the placenta. We don't want to cut through the placenta. We don't want to disturb the placenta. So we gave an incision on the upper segment, had delivered the baby, and the placenta is still inside. Stitched this incision, proceeded with hysterectomy, and we have then after that cut the specimen and showing it, right? So it is not LSCS. It is not LSCS, and it may not necessarily be classical cesarean section. If the placenta, see, one of the indications for doing classical cesarean section, upper segment cesarean section, is a morbidly adherent placenta. That is true. Do we always do a classical cesarean section in a morbidly adherent placenta? Not true. See, it is not like, it's not A equal to B. Okay. So yes, one of the indications of doing a classical cesarean section is a morbidly adherent placenta. In this particular patient, placenta was in the lower uterine segment anteriorly. So I had no choice but to give an incision in the upper segment. Imagine that the placenta is posterior wall of the uterus. Anterior wall is free, then I can give an incision in the lower uterine segment. So the idea is to give it away from the placenta and not disturb the placenta and not cut through the placenta. Okay, fine, clear? Now, next question. You are conducting the delivery of a multiparous woman with gestational diabetes in labor. The estimated fetal weight is 3.5 kg. After delivery of the head, shoulders, so the context is set. I have asked you similar questions on similar contexts earlier in earlier lectures and earlier discussions, but this time I have changed it a little bit. So the shoulders do not deliver spontaneously and head recedes back onto the perineum. This is your clue that this is your turtle sign. And this is shoulder dystocia. I could have asked you what is the first maneuver to be done. This is McRoberts maneuver. But now I am asking you, what is the importance of the following maneuver which is used immediately? Yes, so the correct answer is option number B, straightening the sacrum relative to the lumbar vertebra. So when thighs are flexed onto the abdomen, McRobert is thighs on abdomen, thighs on maternal abdomen. Okay, so thighs are hyperflexed on the maternal abdomen and knees are also flexed at the same time. Knees are kept flexed and slightly abducted. Okay. So with this what happens is that the pubic symphysis, the pubic symphysis tilt upwards. It tilts upwards and there is flattening of the sacrum relative to the lumbar spine. So it changes the alignment of the pelvis. It changes the axis of the pelvis in a favorable manner so that the anterior shoulder that is stuck behind the pubic symphysis slips out, dislodges, gets disimpacts, comes out, right? Now, McRoberts maneuver is thighs on the abdomen. Okay, that is what is McRoberts maneuver. At the same time, simultaneously, we also ask the assistant to put suprapubic pressure. Okay, now sometimes see what happens is, one has to be very careful when we give this suprapubic pressure also. Why? Because we have to adduct the shoulder. So it has to come from the back side. This suprapubic pressure has to come from the back side. All right. So that is also very, very important point to note. So suprapubic pressure is in addition. The priority maneuver is McRobert maneuver. The why it works, it is causes favorable alignment. It causes straightening of the sacrum relative to the lumbar vertebra. It decreases the angle of pelvic inclination. It does not increase the pelvic dimensions. No, it does not do that. And we are not rotating the shoulders for delivery. Those are internal rotational maneuvers where we actually rotate the shoulders, right? Which are wood corkscrew and which is Rubin's maneuver. There you are rotating the shoulders. So this is not, we are not rotating the shoulders here. Okay, fine. So this is your answer. Now, a very interesting comment I read from Sanvi. In retained placenta, it may be due to trapped, no signs of placental separation or accreta spectrum. The next step is USG. Well, see, USG, you are right, potentially USG is the next step if one can arrange for a bedside USG. Okay, see, how does the USG change your management? Let me just take that up. I really like it when when you question, because that kind of increases the scope of discussion. That's very interesting. So you said that next step is USG. Yes, of course, next step is USG when you want to differentiate between whether it is actually a morbidly adherent placenta that has gotten retained, or it is just a retained placenta that is just trapped inside. Now, if it is just trapped inside, then the upper segment is contracting. It is trapped in the lower uterine segment probably, right? So bleeding won't be there much, right? So one, if possible, one can attempt for an urgent bedside ultrasound, but it necessarily will not change the management. As long as there is no bleeding, I can still wait for another 15 minutes, thinking that yes, most of the times it is a trapped placenta. There is no PPH, maybe it is a trapped placenta. So I give another 15 minutes, and then, and I am attempting controlled contraction, so it may deliver, right? So that is the goal. If it doesn't come out, even if it is trapped, it may be trapped, the placenta may be trapped behind a lower uterine segment. Placenta upper segment is contracted, and the placenta is trapped here. Placenta is trapped here, and the os is closed. Os is closed. Os is closed. Okay, so even if you make this diagnosis on ultrasound, does it change your management? No, na. You still take the patient to OT, you still relax, you still go for the anesthesia. See, manual removal of placenta has to be done ideally in OT under anesthesia, right? So, you can do an ultrasound, can come to a diagnosis, that would be good. If one can arrange for an urgent bedside ultrasound, that would be good. But even if this is the circumstance, you still will have to take the patient to the OT and attempt for the manual removal process. So, कैसे निकालेंगे? If the os is closing and you'll have to relax the os, relax the lower segment, and then attempt manual removal. The only thing that is it would be that it will come out very easily. Manual removal will be very easy in this situation. Sometimes one can also feel the edge of the placenta when we are doing the PV, and we know that okay, placenta yahi to hai, it is just there, like that. Okay, now come to think of it, supposing we ended up in a situation where it was here, it was retained and placenta was here, okay, supposing it never bled, supposing there was a morbidly adherent placenta and it never bled. 15 minutes went by, no PPH happened. I attempted manual removal of placenta. I put my hand inside. Now imagine, I am attempting manual removal of placenta, and very easily I find the plane of placental cleavage and I complete the procedure and I come out. That means it was not morbidly adherent. It just so happened that it was adherence. It was not even trapped, it was adherence. It had not separated, but it was not morbidly adherent. And when I attempted manual removal of placenta, I was able to achieve the plane of cleavage and bring it out, right? So, it may not necessarily change your management, right? Clear? So, Ishita, now you're getting my point. So, sometimes the diagnosis of whether it is truly a morbidly adherent placenta can only be made in this situation, that during MRP, if plane of separation not found, placenta separated in bits and pieces, unfortunately, I end up discovering, finding morbidly adherent placenta as a surprise diagnosis. And such patient, then we try what we can, we try to separate as much of placenta as we can, but sometimes there is so much bleeding, they may end up with an emergency hysterectomy. That happens. But most of the times we are able to. If it is not a morbidly adherent placenta, we are able to find the plane of placental separation, plane of cleavage, and we are able to complete the manual removal of placenta and come out. So, we now know that it was not morbidly adherent. And that is why focus is now shifting also in making the antenatal diagnosis of morbidly adherent placenta. Clear? Are we clear? Ishita, you raised this very interesting question. Now, next question. 28-year-old G2P1L1 comes to routine ANC at 37 weeks breech presentation. 37 weeks breech, had a cesarean section for fetal distress in her last pregnancy 3 years ago. Ultrasound confirms healthy intrauterine fetus, flex breech, estimated fetal weight 3 kg, AFI 10, placenta fundal. No, nothing wrong. From reading the question, I realized that the only issue is breech. The only issue is breech with previous cesarean section. Now breech with previous cesarean section. That is the situation. All of the following options are offered except A, D, B. अच्छा, एक बार ऐसे सोचो, she's come for routine ANC visit, है ना? That is why I said get the gist of the question. The gist of the question is she's now breached previous cesarean section, come for routine visit. There is no other issue. So why would you want to admit in LR for cesarean section? अभी क्यों करना है? Why right now? She's now breached, agreed. She's previous cesarean section, agreed. Even if you want to do a cesarean section, why will you do it right now? Right? So, even if we have to do an elective cesarean section, we will wait till 39 weeks until and unless there is some other reason to do it earlier. Okay. So, when we are doing elective cesarean sections in a woman with previous cesarean section, one previous cesarean section, when we are doing elective cesarean sections for breech maybe, whatever reason, nobody is asking you that, right? But what is important to understand here, what they are asking you is that there is no urgent need right now to do a cesarean section immediately. Right. So, admit in LR for cesarean section is not offered. Why will I suggest this to her? Okay. She has the option of opting for breech vaginal delivery whenever she goes into labor. Previous cesarean section is not an absolute contraindication for breech vaginal delivery. If she says, I don't want a breech vaginal delivery, that's fine. Schedule an ECV in the next few days. External cephalic version can be attempted in this situation also. Previous cesarean section is not an absolute contraindication. One does not prefer is another matter, but it is still an option open. She'll say, no, I don't want. Then of course, you can schedule an elective cesarean section at 39 completed weeks. That's correct. Okay. So, right now this option is also there. This option A is also there for her. Option C is also there open for her. Option D is also open for her. But as of now with her profile, there isn't any reason why I should do it right now. Why I should admit an LR for cesarean section right now. So, when we look at the clinical management of breech presentation, all women are offered external cephalic version. They are offered external cephalic version. They may choose or they may not choose is another matter. But these are the prerequisites that need to be fulfilled. There are only two absolute indications for cesarean section. Two absolute indications for cesarean section. footling breech and breech with hyperextended head, which we also call as stargazer breech. And there are situations where cesarean is preferable. There are situations where cesarean is preferable. These 7 situations. So basically, in a nutshell, remember, complicated breaches. One prefers cesarean section. So for your question, when previous LSCH and breech are present together, do we still prefer vaginal delivery? No, we don't. Okay, previous cesarean section with breech, we generally tend to prefer cesarean section. However, external cephalic version is not absolutely content. Previous cesarean section, macrosomia, big baby, these are not absolute contraindications to external cephalic version. Okay, so in a nutshell, look at this. Patient requests large fetus, big baby as previous cesarean, right? Preterm, apparently healthy, viable preterm, severe fetal growth restriction, prior perinatal distress. So some of the other complicated breaches, generally we prefer cesarean section. Okay, now for transverse lie, is it not an absolute indication for LSCS? Okay. You see a transverse lie in the OPD at term. You will offer external cephalic version. In fact, with transverse lie, external cephalic version would be much easier. And instead of rotating the baby 180 degrees, all you have to do is do 90 degrees of rotation to make it cephalic, isn't it? So please remember here, bache, we can do ECV for transverse lie also. Same prerequisites. For transverse lie also, after fulfilling the same prerequisites. Transverse lie, again same prerequisite, offer external cephalic version at term. 36, 37. 37 is what we usually do. 37 weeks pay we usually do. But supposing some patient came to me directly in labor with transverse lie. Dilated. Now I can't do external cephalic version then at that time. So now I will go for an emergency cesarean section. If there is a patient with transverse lie and I have to schedule an elective cesarean section for her, then 39 weeks. Elective cesarean sections are generally scheduled at 39 completed weeks unless there is a reason to do so earlier. As simple as that. So generally 39 weeks unless there is some reason to do so earlier. Now remember those earlier situations. Like for example, when we are planning an elective cesarean section for placenta previa cases, it is 37 completed weeks. Supposing we are planning an elective cesarean section, like we'll just write here, elective cesarean section in a woman with previous history of uterus or scar rupture, then the timing has to be 37 completed weeks. Diabetes not when controlled, yeah. But see, diabetes not well controlled is not an indication for, who's asking me? Yeah. Dr. Strange, diabetes not well controlled is not an indication for a direct cesarean section. Diabetes not well controlled can be an indication for induction of labor. Okay, fine. Okay. Now next question. Now your transverse lie questions, Supriya, have a look. Okay, unbooked multiparous, seen in emergency in labor, context set, what would be the best course? They are asking reposition cord back inside, internal podalic version, weight, cesarean, all that. Okay, so you got your options, 4 options that you have to choose from. So you kind of judge that the situation is of cord prolapse. Reading into the question, going into the question, Please set the context clear. That is how the art of reading a question is also very important. Set the context. You're reading a question about cord prolapse. Vitals are stable. Per abdomen, she is term, but she's 30 weeks per abdomen. Fetal head is palpable in the right flank. That's your keyword. Key clue actually. The FSH cannot be localized on stethoscope. On local examination, umbilical cord is lying outside the introitus and cord pulsations are not felt. What would be the best course of action? Yes. Okay. So first of all, let me tell you that repositioning the cord back inside the vagina is something that is not encouraged, especially from undergraduate students. Okay. I have not seen a question being framed like that so far where repositioning the cord inside the vagina was the answer. Okay. Because I will not frame a question like that where I will expect an undergraduate student to touch the cord, handle it, fiddle with it, and try to reposition it anywhere. Yes, gentle handling of the cord can be attempted. वो बोलते हैं कि उसको keep it inside the vagina, use a wet gauze piece soaked with saline and gently handle it and put it inside the vagina. All that is fine. But undue handling has to be avoided, period. Okay. So from undergraduate students, this is not accepted. At the most, what we expect undergraduates to do is, yes, know the positional changes. Okay, we put the woman in Trendelenburg, right? Or a Trendelenburg position, head low position works best, because what happens is cord that is slipping out can automatically slip inside the vagina. You avoid additional fiddling also. So focus on that, focus on positional changes, right? So repositioning the cord back right now, not the answer. Then another way how we can avoid the cord compression and everything is retrograde filling of the bladder. That's also a good thing to do. Okay, because like making the knee chest position, making the Sims position, they need patient cooperation also. So clinically speaking, Trendelenburg head low position, very good. OT tables can be made into OT tables, so sometimes labor room tables can be made into head low position. Otherwise, you'll have to put a buttock underneath the buttocks and achieve that position. So yes, that is there. Now, they are saying that umbilical cord is lying outside the introitus and cord pulsations are not felt. FSH also cannot be localized. So, you are in a situation where the baby is already dead. Baby is already dead, most likely. Okay, I would want to confirm, yes, would confirm with urgent ultrasound for cardiac activity before labeling the baby as dead. Okay. Also the reason, because she's been unbooked. She's come from outside, right? And it's been quite some time that the cord probably has been lying outside. Now it is transverse lie. Transverse lie with cord prolapse with baby already dead. So now best course of action would be a cesarean section. Okay, best course of action would be a cesarean section. Okay, spontaneous vaginal delivery will not be an option for transverse lie in labor, because there will be no mechanism of labor. It will end up with an obstructed labor. Repositioning the cord back inside the vagina, I am not picking up as the best course of action. And internal podalic version and vaginal delivery is an option only for second twin in transverse lie, nowhere else. Okay, only in second twin in transverse lie, right? Now, bache, the basic difference between the external cephalic version is per-abdominally we are rotating the baby. Okay, from breech or from transverse lie we are making it cephalic. Per-abdominally we are moving the baby. Internal podalic version and external cephalic version. External cephalic version, per-abdominally externally moving the baby, bringing the head cephalic where it should be. Okay, down. So external cephalic version, making any breach or transverse lie into cephalic. Internal podalic version, second twin in transverse lie. Go inside the vagina, we rupture the membranes. Now, if you just kind of think about it, okay, you have a bag filled with water and there is a ball inside, okay. If you just imagine, it is very difficult to grasp that slippery head or a slippery ball like this. वो grasp ही नहीं आएगी. You have internally, we will have to grasp the feet. Feet will be grasped. Podalic. Feet are grasped. Baby is made breech. Feet are pulled out and then the baby is delivered. So podalic version and then the baby is delivered as breech. With breech extraction is done using all the maneuvers and everything. That is internal podalic version. Only one place where it can be attempted is second twin in transverse lie. Why can't you do it right now? Because the uterus is contracting. When you have a second twin, twin 1 delivered, second twin has to deliver in. So it is first twin ka labor, second twin ka labor. In between these two labors, the uterus kind of rests for a couple of minutes. Okay. So one twin delivered, वो labor खत्म हुआ, uterus will rest for some time, a couple of minutes. Then contractions will start again for the labor of the second for the second twin again. So you have that window, we have that window of opportunity where the uterus is relaxed and internal podalic version can be attempted, because with a contracting uterus it's not possible to do internal uterine maneuvers. Okay, why the hell were we doing all of this repositioning and manual removal of placenta under anesthesia? Okay, we need the uterus relaxed for these internal maneuvers. Okay, clear? Now, Pranati, baby is already dead, then why do cesarean section? How else will you deliver this baby, even if it is dead? How else will you deliver this baby? Tell me. See, when there is cord prolapse, supposing there is cord prolapse, and cord prolapse can happen with cephalic presentation also. Head high up, cephalic presentation था, cord prolapse हो गया. Cord prolapse हुआ and when I did a PV, it seemed as if mother was bearing down and लग रहा था कि baby अभी deliver हो ही जाएगा. ठीक है, हो जाएगा, right? So cord prolapse, vaginal delivery can be attempted. Let's say for example that vaginal delivery is just about to happen. कॉर्ड प्रोलैप्स हो गया, बेबी डेड है, वेजाइनल डिलीवरी पॉसिबली होती तो करा देते, इसमें तो पॉसिबल ही नहीं है तो कैसे कराएंगे? देयर इज नो अदर वे टू डिलीवर. सो इवन इफ द बेबी इज डेड विद ट्रांसवर्स लाई एट टर्म इन लेबर, प्लीज रिमेंबर ट्रांसवर्स लाई ओनली इन एक्सट्रीम प्रीमेच्योरिटी केसेस विद अ डेड मैसरेटेड एक्सट्रीम प्रीटर्म बेबी. Is there a possibility ever, very rare though, of having a vaginal delivery? But with transverse lie, it's destructive procedures, all that is not done anymore. So it's cesarean section. Okay. All right. Now cervix fully dilated, then only vaginal, right? Yeah, cervix has to, obviously cervix has to be fully dilated, then only one can go for. So supposing, now see, so many questions. You have to understand concept and logic. Supposing this was cord prolapse with cephalic presentation, baby already dead, and cervix was partially dilated, you'd go for a cesarean section. Yes. Divya, cervix fully dilated, then only vaginal, right? ये क्या sentence हुआ? Then only, ऐसा नहीं, कॉन्टेक्स्ट पे लॉजिक समझो और उस पर मल्टीपल कॉन्टेक्स्ट बन सकता है. फिर बना दो कॉन्टेक्स्ट, है ना? तो if in this situation this was cord prolapse, cephalic presentation, already dead baby but partially dilated cervix, तो हम vaginal delivery attempt करते? Then why do a cesarean section for a dead baby? Isn't it? And S.S. Sharma, we can't give induction in this case because induction has to be done. क्यों करना induction? Answer this. See, why would you want to go for induction? For her to deliver? She's already come in labor. She's already come in labor. Induction is done with a goal to achieve a vaginal delivery. Induction में क्या करते हैं? In induction we give drugs to ripen the cervix. In induction we give drugs to increase the contractions. मकसद क्या है कि भाई ओके डिलीवरी होगी. कैसे? How? Why vaginal route? That is why we are doing induction. So the biggest thing that we want to see when we are doing induction is vaginal delivery possible and feasible? Then only we will go for induction. Okay, so one is deciding that we have to deliver. Once we have decided, then we decide, okay, what should be the route? If the route can be vaginal, wherever possible, wherever feasible, if I have decided to deliver by vaginal route, then yes, induction can be done. Okay. Clear? Petals in places. If it was encephalic and not in labor with maternal vital stable, then induction of labor. Yeah. Yeah. Yes. Okay. Chalo, let's move on. Next question. During active management of third stage of labor, immediate, so somebody was asking me, one of you people had mentioned in the chat boxes, updates for AMTSL. So here we have the question on AMTSL, and it is an old, often repeated question. I'll give you the update. Even with the update, most of the time your answers will not necessarily change. During the active management of third stage of labor, immediately after delivery of the baby, which intervention is recommended to prevent PPH? So early cord clamping is definitely not part of this thing. We want delayed cord clamping. Delayed cord clamping is the norm for all vigorous babies, irrespective of birth weight. Irrespective of birth weight, delayed cord clamping has to be done. WHO say delay is anything between 1 to 3 minutes is good enough delay. It should not be less than 1 minute. ओके, लेस देन 1 मिनट हो गया तो वो डिलेड की डेफिनेशन में नहीं आएगा. डिलेड कॉर्ड क्लैंपिंग एनीथिंग बिटवीन 1 to 3 minutes इज गुड इनफ. डिलेड कॉर्ड क्लैंपिंग, इट शुड डेफिनेटली बी एटलीस्ट 1 minute of delay, not before 1 minute. So delayed cord clamping is there, and fundal massage is not the component of active management of third stage of labor according to WHO. It has never been, right? And oxytocin 10 units IM or slow IV immediately after the delivery of the baby, preferably within 1 minute, has to be done, and this is the most important component. Uterotonics is the most important component. That is why it is the best answer to choose, not controlled cord traction with immediate removal of the placenta. First priority is to give oxytocin. That is why it is the best choice answer. So according to WHO, what are the components? Delayed cord, first of all, immediately after delivery of the baby, give oxytocin. Follow delayed cord clamping and delivery of the placenta by controlled cord traction. Okay, and now intermittent uterine tone assessment has become a part of fourth stage management. Okay, so now intermittent uterine tone assessment has become a part of fourth stage management. Okay, fine. Now, and also remember that control cord traction has to be done only by trained healthcare professional. Okay, now vigorous, yes, when I say irrespective of birth weight, it means baby term, preterm, doesn't matter. Okay, and when we are doing early cord clamping, yes, early cord clamping when we are doing, we can milk the cord. Okay. दीपक, डिलेड कॉर्ड क्लैंपिंग, ये डिलेड कॉर्ड ट्रैक्शन क्या होता है? कुछ नहीं होता है डिलेड कॉर्ड ट्रैक्शन. Okay, now we are talking about, is IV preferred now? That is your next question, isn't it? So let's talk about the route. Okay, so what is the WHO update on this? WHO update on this, and I'll tell you what, WHO ने तो अभी update किया है, but if there's anybody in the audience, any of you who has actually seen cases being done in the OT, if you've ever witnessed, if you've ever seen a cesarean section being performed, answer this question to me. Where do you think the anesthesia people give the oxytocin immediately after delivery of the baby? See, active management of third stage of labor has to be followed irrespective of how we are delivering. No, whether it is vaginal delivery, whether it is cesarean section, it doesn't matter. AMTSL is always done. एक्टिव तो कर हमेशा करते हैं, राइट? अब इन लेबर यू मस्ट हैव सीन, यू से ओ सिस्टर पुट ऑक्सीटोसिन एंड शी विल पुट इट वेयर, शी विल पुट इट इन हर बटक्स, 10 यूनिट्स IM लगा देगी वो, बिकॉज IV लाइन है ही नहीं. अब शी विल नॉट वेस्ट टाइम ना कि आई विल फर्स्ट अप्लाई IV लाइन एंड देन आई विल गिव IV. नो, IV बोलस इज नेवर गिवन. प्लीज ऑक्सीटोसिन इज स्टिल नेवर IV बोलस नहीं देते. बट हाँ, supposing she already had an IV line, supposing she already have an IV line, then sister could have given her in the IV vac, 10 units IV vac में डाल देते हैं हम लोग, कोई दिक्कत नहीं है, right? Similarly, in the OT when we are doing cesarean section, patient तो is lying supine, right? Her buttocks are not accessible for IM injection, she is wearing her OT gown, right? And the deltoid is not available for giving injection, and she immediately after delivery of the baby, you hand the baby to the mother. उसको मदर को दे देते हैं बेबी, मदर स्किन टू स्किन कॉन्टैक्ट के लिए, तो कैसे लगाएंगे? एनेस्थीसिया पीपल दे पुट इट इन द वैक, sometimes they give half dose slow IV also, right? So वो हम पहले भी कर रहे थे. Okay, so the WHO is the WHO recommendation is, right? And yes, it is oxytocin infusions, they should not be given with DNS, dextrose containing solutions basically. They should be given with RL preferably. So WHO update is that when we are talking about, the dose is the same, 10 units. Okay, IV slow or infusion preferable. Infusion preferable if IV line already present, otherwise yes, 10 units IM. Okay, this is the drug of choice. Oxytocin is the drug of choice. Oxytocin is the drug of choice. Next drug, next drug, carbitocin, 100 micrograms slow IV. Nowadays heat stable formulation is available. सरकारी अस्पतालों में ये अभी भी नहीं है, but still heat stable formulation is available where it can be made available. This will be a good idea, or this is a good alternative in situations where cold chain cannot be maintained. But हमारे peripheral health care centers में, community health care centers में carbitocin available नहीं है अभी फिलहाल. ठीक है, नई सरकार नहीं, writing down it in papers and having it actually on the ground are two different matters. Okay, so yes, carbitocin is a good alternative, second choice drug in place of oxytocin if cold chain not maintained, not possible or whatever. And the third is misoprostol. अब ऐसी situation where we cannot arrange for carbitocin, we cannot arrange for heat cold chain, and misoprostol can be given safely by lay healthcare workers also. Oral 400 to 600 microgram, third choice. no other drug. Okay, methergin मैं हमेशा बोलती थी, and I kept telling, so I have never used methergin for active management of third stage of labor. We never did, never ever did for third stage management. Methergin can cause retained placenta. Okay, so methergin, methergin, centometrin combination, all that. Injectable prostaglandins, not recommended. PGE2 dinoprostone, not recommended. These are the only 3 drugs which are recommended for active management of third stage of labor. Okay, and yes, carbetocin and oxytocin on a molecular, they are same action wise. They are same action wise. The oxytocin, the synthetic oxytocin, syntocin, non-pitocin that you get in those vials which you see stored in the fridge, that is recombinant oxytocin, and that contains 9 amino acids just like the natural oxytocin. Carbetocin is an analog. Synthetic oxytocin analog containing 8 amino acids instead of 9. It is long acting basically. It's an octapeptide, okay. So it's a long acting analog. That's the difference. Otherwise, action wise they are the same, but half life. With carbetocin we'll have a longer half life as compared to synthetic the oxytocin. Okay. Next question. According to the latest WHO recommendation, early detection of PPH primarily within the first 24 hours of birth is important in preventing morbidity and mortality. The first response treatment bundle is initiated when? I'll just change the options. Just wait. I want to change the options for you. Now give me the answer. Just change the options for you. Yeah. First response treatment bundle is initiated in all situations except. अब मैंने एक्सेप्ट निकाल लगा दिया. I have added except. In all situations except. Okay. In all situations except. Yes. Now you know, shock index less than 1. Okay, so shock index less than 1 is your answer here. Shock index is basically systolic BP. Shock index is basically heart rate divided by systolic blood pressure. So shock index more than 1 is abnormal. Shock index more than 1 is abnormal. Okay, so keep that in mind. Now, according to date, है ना, so according to WHO recommendations, ये जो recommendations हैं, what purpose they are serving, okay, you'll have to understand these recommendations in a context. That is how you will remember it. कि define क्या कर रहे हैं? We are not defining PPH for government record keeping, for all that. We are or for research purposes. What we are defining PPH is in a clinical perspective. कि हाँ भाई, what we are going to do is we are going to objectively document the blood loss. अभी तक क्या होता है लेबर रूम में, तुमने देखा होगा कि PPH हो रहा है और वो everything is visual estimation, है ना. And according to that visual estimation, हम लोग क्या करते हैं कि जैसे ही uterus, what we tend to do is that once we have followed active management of third stage of labor, once the placenta has delivered, I am expecting कि भाई अब तो uterus contract होना चाहिए. If the uterus is still relaxed, one starts with the atonic PPH and PPH management protocol. Now they are also saying that objective documentation of blood loss is very important. जैसे कि मान लो we have these drapes that are calibrated drapes are there. So whatever bleeding that happens, it collects underneath the drape, and one can actually have an objective assessment, objective documentation and measurement of blood loss, right? Especially within the first 24 hours of, primarily within the first 24 hours of birth, usme bhi especially in the first 2 hours. And this is irrespective of whether it was a vaginal delivery, whether it was a cesarean section. Okay, so this is all irrespective of mode of delivery. This is all irrespective of mode of delivery, right? So blood loss more than 500 ml अगर हो गया है, then you start with the first response treatment bundle. Then don't wait for the woman to deteriorate, hemodynamically. So blood loss more than 500 ml, whether it is vaginal, whether it is cesarean section, doesn't matter. Start acting, okay? And then they are saying is, supposing if the blood loss is less than, supposing the blood loss is more than 300 ml only. Abhi only 300 ml blood loss threshold has been crossed. But signs and symptoms of hemodynamic instability have come. So how I remember is कि blood loss अगर 500 ml का threshold आ गया, then I don't wait for the patient to decompensate hemodynamically, I start acting. Supposing blood loss threshold of 500 ml has not yet been reached, but the patient is showing signs and symptoms of hemodynamic decompensation, then we start with the first response bundle. So blood loss could have been more than 300 ml. If any sign symptom of hemodynamic instability is there, then also start with the first response treatment bundle. So what are those signs? Systolic BP less than 100 mmHg, yes, I would like to start the first response treatment bundle. Or diastolic BP less than 60, heart rate more than 100 and shock index more than 1. So these are needed for your rapid identification, okay, early detection of PPH, okay, keep that in mind, all right. And your first response treatment bundle is going to involve, this is an emotive approach where we have early identification, massage, oxytocin, tranexamic acid is in the initial response bundle. Doesn't matter the type of PPH, tranexamic acid, it has to be given. IV fluids, this is crystalloids preferably. And escalation of care, before escalation, examination and escalation. Examine for what? Examine for whether the placenta has been completely expelled or not, examine for retained products, retained bits of placenta, examine for genital tract lacerations, examine for hematomas, and then escalate as needed. So that is the update, okay, fine. Now let's have a look at the next question. 25-year-old woman delivered her first child by cesarean section for arrest of labor. So basically they are giving you a situation where you are assisting senior in a cesarean section. That's the context. What would be the most appropriate next step? If you read the next step, they're talking about B-Lynch, tamponade, devascularization, embolization. So they're talking about a context of PPH. So you read this question with the context set. You are assisting with your senior in a cesarean section case patient. Placenta membranes expelled, uterus atonic, fluid resuscitation, bimanual uterine compression is being done. Obviously now cesarean hua, we delivered the placenta, uterus atonic, uterus is right there in front of me. I am doing bimanual uterine compression. All available uterotonics are exhausted. So we started oxytocin, then we give methergin, then we gave carbitocin, right? Whatever drugs we had available with us, we've used them all. It's not contracting underneath my hands. Patient is getting unstable and 2 units of blood, I have asked for it also, that is also on the way. Most appropriate next step would be balloon uterine tamponade. Patient is already on table. Cesarean कर रहे थे हम, ठीक है, we were doing cesarean, patient is already on table. Logically speaking, the quickest way would be quickest. Logically, the quickest way would be, and especially when we have atonic PPH, compression sutures are priority, not stepwise devascularization. Not stepwise devascularization. Let me tell you this. If I describe stepwise devascularization to you, stepwise devascularization means bilateral ligation of the uterine arteries. उसमें भी uterine arteries high ligation, low ligation ऐसे करते. Bilateral ligation, uterine artery ligation, bilateral ligation of uterine artery on both sides, ligate on both sides. Wait for 10 minutes. Then proceed with the other branch. Ovarian artery, यहाँ ligate करते हैं ovarian artery. Okay. Generally at this anastomosis of uterine and ovarian के branches के anastomosis. Here you ligate ovarian arteries. I don't want to compromise this infundibulopelvic ligament, ovarian artery यहाँ पे भी होती है branch of ovarian artery. But I don't want to compromise the ovaries unnecessarily, so preferably here, but यहाँ भी कर सकते हैं ovarian artery, but preferably here. Wait for 10 minutes, not successful, internal iliac artery ligation. This all takes time. Whenever I have had a cesarean section and there is atonic PPH which is not responding to uterotonics and I want to do something, it is B-Lynch suture. When we say stepwise devascularization, there is a sequence to stepwise devascularization. Uterine, then ovarian, and then internal iliac, which is anterior division of internal iliac. Okay, please keep that in mind. Yes, now, so in the face of atonic PPH, B-Lynch sutures, uterus compression sutures, they become the priority. हम tamponade कर रहे थे ना बाहर से. Compression sutures का क्या मतलब होता है? Sutures, we put the B-Lynch sutures and it helps with the external tamponading now. Helps with the external tamponading now. So the only reason why uterine artery, why stepwise devascularization is not being chosen here, because the patient is hemodynamically unstable, and Williams textbook also clearly states, and we have seen in clinical practice, bache, when the uterus is flabby and relaxed, your devascularization procedures, they generally tend to waste time, and B-Lynch sutures, uterus compression sutures, they work better. So if you will wonder where the hell the uterine compression suture, where the hell would stepwise devascularization procedure would be okay, think about it. Supposing if there is, we are doing a cesarean section and this is the incision, this is the uterine artery. Okay, so sometimes the uterine incision sites bleeds very heavy. Sometimes uterine incision sites bleeds very heavy. Then we can go for uterine artery ligation. That helps. It makes sense. Okay. And bleeding specifically from the lower uterine segment sometimes can be targeted by uterine artery ligation. And so then traumatic bleedings like that can be targeted by stepwise devascularization procedures, but in the face of atonic PPH, it's generally B-Lynch sutures. Okay. Now, why not B? Why not B? Because patient is already open and the patient is unstable also. But main reason is that patient is already open laparotomy. The reason why we were doing a balloon uterine tamponade was to avoid a potential laparotomy. अब तो खुला ही है पेशेंट, एनेस्थीसिया में भी है, तो ऐसा इंटरवेंशन कर दो विच विल शो शॉर्ट वर्क. सो दैट्स वाई नॉट बलून यूट्राइन टेम्पोनाड. बलून यूट्राइन टेम्पोनाड ऐसा नहीं है कि हम सिजेरियन केसेस में नहीं कर सकते. वी कैन डू इट इन सिजेरियन केसेस ऑल्सो. इट्स नॉट लाइक दैट. But yes, when the uterus is atonic and the patient is hemodynamically unstable, B-Lynch sutures is a priority. Balloon uterine tamponade not the most appropriate in this particular clinical context, because we were attempting it with the hope that agar this tamponade would have been successful, then we would have potentially avoided a laparotomy. That's why not the answer. And uterine artery embolization. अब यूट्राइन आर्टरी को लेप्रोटमी करके बाहर से टाई कर दो. वेदर यू लाइगेट द यूट्राइन आर्टरी आफ्टर डूइंग अ लेप्रोटमी, बिकम सर्जिकल, और यू go for embolization of the uterine artery, block the uterine artery, radiological interventional procedure. Purpose is the same, to reduce the uterine artery perfusion of the uterus, so that bleeding would be less. Embolization procedure has to be done. Radiological interventional radiology is needed. So you'll have to mobilize the patient to somewhere where this interventional radiology is happening. Okay. Concept of hybrid OTs is there, but it is very high and again not available everywhere where interventional radiology, OT, everything is there. It will not be a part of gynae OT for all I know most of the times. So the limitations are there of uterine artery embolization. So it cannot be an option for women who are actively bleeding profusely, getting hemodynamically unstable. And if you're going for uterine artery embolization, you are going via the femoral artery route. Okay, femoral artery cannulation you are doing. You can't do it for women who are having coagulopathy. Otherwise, they'll bleed from there. So limited situation, stable, no coagulopathy, slowly trickling blood may be. So uterine artery embolization is an option for those people, not here. Okay. Now petals and places, when we have to ligate the uterine artery at this location, we ligate it as close to the uterus as possible. In fact, taking a bite of the substance of the uterus. It has to be flushed with the uterus tissue as close to the uterus as possible, keeping in mind that the ureter is just about, the ureter is nearby. Yes? Okay. Now, next question. A pregnant woman at term fell on her stomach and now she has come with complaint of continuous pain abdomen, bleeding PV and since that episode. So, trauma and bleeding and pain, APH. Context set, what is not done in the management of PPH? She is term. Okay, I am telling you the ways to analyze reading the question is also very important, because when you say not done in the management of APH, bleeding, trauma patient, टोकोलिसिस सबसे ज्यादा मेरे को लग रहा है कि टोकोलिसिस तो यार नहीं करना चाहिए इसमें, राइट? टोकोलिसिस शुड नॉट बी डन. So on examination, uterus is term size, tense, tender, getting contractions. So now you know, now your context is said, now you know she is abruption, she is APH patient, uterus tense and tender, and she is getting contractions. Fetal heart rate is so far fine. She is hemodynamically fine, right? So this is abruption. Ultrasound has been done in an emergency. It is placenta is in the upper segment. ठीक है, no retroplacental clots are seen. Maybe everything is revealed. It is not a concealed hemorrhage. So everything is revealed. No retroplacental clots are seen. It is abruption. What is not done in the management? Not done. Not done. Why would you want? She is probably in labor. She is most likely in labor. She is getting contractions. She is getting contractions. Do you want her to deliver or not deliver? पढ़ते हो ना, antepartum hemorrhage, placental abruption, management delivery. Don't you read this? Most of the times management delivery. So you want her to deliver? Yes, because the bleeding is going to stop once the placenta is out and the uterus will contract. That is the only solution for a bleeding that is ongoing like this. So tocolysis or to arrest labor you will not do. Okay, augmentation of labor you can do. Yes, of course. I mean, we'll proceed with the per-vaginal examination now. Now, once we have ruled out where the placenta is, see, we have emergency ultrasound has been done. Placenta is in the upper segment. There is no previa. She was getting contractions. Now, I can do PV. I can do PVC if she is already in labor. How far is she in labor? Is she in early labor? Is she already in active labor? Can I go for ARM? Will I be able to do ARM? If I am able to do ARM, I will see blood stained liquor. My diagnosis will also be confirmed. It will help in augmenting the labor also. Then I can decide if oxytocin is needed or not needed. So yes, I can go for augmentation. I will go for PV. I will also send for urgent investigations, arrange for blood. Do not forget the simultaneous resuscitation part of bleeding obstetric patients, right? So for now, yes, tocolysis to arrest labor is not needed, right? So that is your answer. So previa versus abruption. Please remember, with abruption, your antecedent history of abdominal trauma will be there. Bleeding can be bright red also, but altered, dark colored bleeding goes more in favor of abruption. If she had retroplacental clots, do we still proceed or do tocolysis? Supriya, that is irrelevant, because if she had retroplacental clots or not, it doesn't matter. That would not have changed your diagnosis. Clinical placental abruption is a clinical diagnosis. If she had retroplacental clots, that would mean that she is having concealed hemorrhage. And sometimes ultrasound cannot differentiate between clots and placenta. They look very similar. So we have seen cases where it was concealed hemorrhage clinically, and sonologist report did not mention anything on retroplacental clots, but we still proceeded with our management. Okay, so it won't matter. All right. Now pain is going to be there, fetal heart rate, distress goes more in favor of abruption, but fetal heart rate could be normal also, depending upon how much of the placenta has separated. Uterus tense, tender, sometimes they will write woody hard uterus, sometimes they may write woody hard uterus. And tone is increased, uterus tone is increased. So in between contractions, uterus is not relaxing completely. That is what increased tone means. And अच्छा ये तो fetal heart sound हो गया. Fundal height could be more than POG or it could be equal to POG also. That depends. Fundal height more than POG would be if there is a lot of blood that is collecting behind the placenta, like in concealed hemorrhage. Otherwise, it may be equal to POG also. And placenta previa will have painless, causeless bleeding. Usually, the first episode is warning hemorrhage. Okay, first episode is warning hemorrhage. So when patient generally comes from the first episode, that is going to subside on its own, but there is no way of predicting when will that happen again and how much blood loss will happen again. So ideally, these patients with antepartum hemorrhage should be kept admitted and evaluated. Fundal height corresponds to POG. With placenta previa, malpresentations, free floating head, they are also very likely. Uterus most of the times is going to be relaxed unless she is already in labor. Fetal heart rate is also usually normal. Please remember, PS and PV is not done. First we have to do for ultrasound. First we have to rule out previa. First priority is to rule out placenta previa. Please remember, generally we are going to start with transabdominal sonography, TAS first, right? But if the sonologist needs a transvaginal sonography, is also safe. Okay, TVS is also safe. Okay, now see, etiology of abruption and previa, we can't make this, this is a last minute rapid revision, we can't make this a routine lecture, but just to give you a broad perspective that with abruption, abdominal trauma, hypertension are most important preceding risk factors. Why? Because there is some or the other, the placenta has managed to separate prematurely from wherever it is normally attached. So abdominal trauma could trigger that separation, hypertension could trigger that separation, especially because of the rapid flow of blood flow across these fragile spiral arterioles. Placenta previa, painless, causeless bleeding. Placenta is in the lower uterine segment. It is not supposed to be there. In the lower uterine segment, obviously you know that formation of lower uterine segment takes place near to term. So most of the times placenta previas generally bleed at term, because that is when movement in the lower uterine segment is taking place. Also, placenta previas and low-lying placenta, they cannot be allowed to deliver vaginally, because once the cervix is going to open up, that is where the placenta is, so it is going to bleed like crazy, right? So these are the two instances when previa patients will bleed. All right. Now, management of placental abruption, simultaneous resuscitation and vaginal delivery, again reminding you wherever possible and feasible should be done. Okay. DIC with abruption, we have to go for correction of DIC. DIC is not an indication of cesarean section. Okay, so if DIC is there and we do a cesarean section, she is going to ooze from the incision sites. Okay, she is going to continue bleeding from the oozing bleeding sites also. So correction of DIC, that means transfuse, FFPs, cryoprecipitates, whatever, and at the same time attempt vaginal delivery. Okay, indication for cesarean section, most important is fetal distress. Then you are doing cesarean for the fetus's sake. And if any contraindication to vaginal delivery is there, then also we go for a cesarean section. Okay, far from delivery with severe abruption, this is the third indication for cesarean section, but this is something that is controversial, so just keep it way down in the list as the third complication. And most common fetal complication with abruption, most common fetal complication with abruption, if they ask you, is prematurity. Prematurity. Why? Because most of the times these patients will end up delivering. Okay, will end up delivering and will end up with the premature preterm newborn. That's why. Okay, so keep that in mind. Now, let's have a look at petals and places. This is your question of previa. Attempt this question and then we'll talk about the management of previa. 28-year-old woman, G2, P1, L1, 38 weeks gestation, early labor, history of cesarean section done 3 years ago. The obstetrician decides on cesarean section. Which of the following is not an indication for cesarean section in this patient? In this patient. So, 38 weeks term, she is in early labor. The only thing that is here is previous cesarean section right now. And the obstetrician has decided for a cesarean section. Okay, so if she was previous cesarean section in labor with low-lying placenta, yes, I would have done a cesarean section. If she was previous cesarean section with in labor with signs and symptoms of uterine scar dehiscence, I would have done a cesarean section. And if previous cesarean section patient is there, she is in labor, she is having non-reassuring fetal status, yes, I would have done a cesarean section for her. But a previous cesarean section patients in early labor, gestational diabetes mellitus by itself is not an indication for a cesarean section. So, the best answer to choose here is option number D. So, I think all of you attempted this correctly. Okay, all of you attempted this correctly. Good. So, when you have a bleeding placenta previa, let's talk about the management of placenta previa was left. Okay, management of bleeding placenta previa. First of all, admit and resuscitate. Okay, if she is already term, any present, if she is already term, already in labor, hemodynamically unstable, emergency cesarean section. Okay, fetal distress is there, fetus is viable and fetal distress is there. Fetus is viable and fetal distress is there. You see here, you don't have to mug this list up. I'm telling you, don't have to mug this list up. Placenta is in the lower uterine segment. The situation is risky for the mother. Okay, because this is even in placental abruption bleeding, it is maternal blood loss. Okay, just to compare the two, even in placental abruption, distress was more likely, fetal distress was more likely because placenta was separating. The connecting link between the mother and the fetus is the placenta. Fetus is getting oxygen from the placenta. Okay, so think about it. This is maternal blood loss, mother's life at risk. Placenta separated, depending upon how much of the placenta has separated, how much fetal distress is happening, fetal death could also happen. So, fetus life at risk. So, both people's life at risk. So, you start resuscitating the mother simultaneously and you start with the process of achieving a delivery simultaneously. That's the logic. Okay. Now, if you compare that with placenta previa, okay, if you compare that with placenta previa now, what is the problem with placenta previa? Placenta previa problem is that, okay, initially fetal distress is not the main thing that is happening. Even distress can happen in previa cases when there is massive maternal hypovolemia. It's not like it's absolutely implausible, it may not occur any time, but initial presentations doesn't happen. No, if this option changes to pre-gestational diabetes, then also we would not have gone for a cesarean section. Okay, diabetes by itself is not an indication for cesarean section by itself. Okay, fine. Diabetes particularly. So where was I? I was at bleeding placenta previa. So when there is placenta previa bleeding, again immediate threat is to the life of the mother. Okay, now I want to deliver because that's the only way bleeding is going to stop. eventually, right? So understand here that I want to deliver for mother's sake, isn't, because see, if she's already term, means she's reached 37 weeks. She's already term means she's reached 37 weeks. Then why will I wait for her to bleed? Because she will bleed. If it is a placenta previa or it is a low-lying placenta, she will bleed. As and when she will go into labor, she will bleed. So why will I wait for her to bleed and turn an elective cesarean section into an emergency cesarean section? So if she's already term, it's cesarean section. If she's already in labor, may not be bleeding right now, but could bleed anytime, cesarean section. Hemodynamically unstable, obviously cesarean section. Now if there is fetal distress but the fetus is viable, I am like, okay, fetal distress is happening, bleeding placenta previa, fetus I can save, maternal indication may not be there but fetal indication is there, then for the fetus sake I do. Dead fetus, non-viable fetus, fetus out of the equation. Then why wait for the mother to bleed? Why wait for the mother to decompensate? Fetus is out of the equation and delivery has to be by cesarean section. There is no other way, right? So then answer is cesarean section. Now the only situation where you would want to go for a conservative management, like for example, and this was a previous year question in your INI-CET, that mentioned that the woman is preterm. Okay, that mentioned the woman is 32 weeks or something, and then they had said that she's admitted with mild bleeding, she's stable and everything, she's away from term, right? The fetus is also fine right now. So all of this has to be fulfilled, and please remember that we are doing this for the baby's sake. We are doing this for the baby's sake so that we can at least, have buy some time to give steroid cover and everything, but without sacrificing the life of the mother. है ना, ऐसा थोड़ी है कि कंजर्वेटिव पे चालू किया then we continue with the conservative, no, right? So there has to be no active bleeding, fetus should be viable, there should be no fetal distress, she should not be in labor. If at any point in time her bleeding continues, if any point in time she bleeds again, she goes into labor, then I stop the conservative management and go ahead and go for a cesarean section. So this is conservative management, and this is McAfee protocol. I will keep the patient admitted, intensify the monitoring, keep the blood arranged, advise her rest, and anti-D if RH negative, right? Steroids if less than 34 weeks. Okay. Now type 1, 2 and type 3, 4, ये पुराना हो गया सुप्रिया. Type 3, type 4, type this, all of this. Okay. So right now a situation is, let's say for example, I will answer your question. Placenta previa is when the placenta is partially or totally covering the os, okay, and then there is a low-lying placenta, low-lying placenta meaning the previous classifications 1 and 2 are here. So low-lying placenta is within the lower uterine segment, but the placental edge is within 2 centimeters of internal os. If the placental edge is within 2 centimeters of internal os, there is no vaginal delivery. Think about it like this. Let's think about it like this. Let's say assume that this is the internal os. Okay, this is the internal os. This is the placental edge. Okay, it could be here, posteriorly, anteriorly, wherever it is. Okay, I'm just showing you one side. This is os closed. This is within 2 centimeters of internal os. Okay, let's say I allow her to go into labor. All right, it is not partially or totally covering the os. It is within 2 centimeters of internal os. Os opened as and when she goes into labor, this comes and lies in front of the os. So placental edge within 2 centimeters of internal os, it is cesarean section. Okay, as simple as that. And obviously partially totally covering all internal os, it is cesarean section. That's obvious. Okay. Also remember here one more thing. Scan for placental localization. Has to be done at 32 weeks and then again at 36 weeks. First at 32 and then again at 36 weeks. So there are situations when we have an early, when you have, let's say for example, the level 2 anomaly scan that was done earlier and it had shown low-lying placenta or placenta previa, right? Then you repeat that scan again at 32 weeks. If it is still low-lying, repeat again at 36 weeks. By 36 weeks, plan should be made now. Because see, if she bleeds All this while then management becomes management of bleeding placenta previa. But let's say for somebody who has never bled, somebody who has never bled and she happens to reach 36 weeks, at 36 weeks it was confirmed that it is a low lying placenta or it is partially or totally covering the placenta, please we schedule an elective cesarean section at 37 completed weeks. At 37 completed weeks, scheduling of elective cesarean section is done. How much time this lecture will be? How many questions we have got? We have got, it will be an hour more. It will be an hour more. It will be an hour more to complete the rest of the questions that I have set for you. Okay. Do we need a break for 15 minutes? Do we need a break for 15 minutes, guys? We can take a break for 15 minutes and then come back. You can get your tea, coffee, whatever. And then we can come back after 15 minutes and then we will go for another hour. I'm getting a mixed response about yes or no. I think we should finish then. I think we can finish. I think we can finish. Okay. Chalo, let's finish, because we have a pace set. So I feel that if we have a pace set, I think we can go for another hour and we can wrap it up. Alright, 18-week primary presents with high risk of neural tube defects and low risk of trisomy 21 on quadruple testing. What is done next? Right. So neural tube defects, high risk has been seen on quadruple testing because and low risk of Down syndrome. So this is basically elevated maternal serum alpha fetoprotein levels. That's because of elevated maternal serum alpha fetoprotein levels. What is done next? Okay, NIPT. Again, NIPT, non-invasive prenatal testing, cell-free fetal DNA testing. It is for aneuploidies. Okay, not for neural tube defects. The risk is more of neural tube defects, which are structural malformations. Okay, so now we go for targeted sonography. Now we go for targeted sonography. Okay, so investigation of choice, diagnosis of neural tube defects is made on targeted sonography. Look at these images. These are neural tube defects. Okay, these are neural tube defects, right? So this is anencephaly. This is anencephaly. Okay, this is the anomaly where there's only face and these enlarged orbits are seen. This is what we call as the Mickey Mouse sign, also frog eye sign. Doraemon, quadruple testing positive लिखा क्या लिखा है क्वेश्चन में? There is a primary gravida presents with high risk of neural tube defects and low risk of trisomy 21 on quadruple testing. Quadruple testing में when we go for 4 markers, then we get a combined risk after assessing all the 4 markers. After assessing all the 4 markers, they are saying there is low risk of trisomy 21 on quadruple testing, but maybe it is showing high risk of neural tube defects because of elevated maternal serum alpha fetoprotein levels. Okay. तो ये तो हो गया anencephaly. Then you look at this. This is encephalocele. This could be on the Back also on the spine, then it will become meningocele, meningomyelocele. This is the baby skull, transverse section of the baby skull. Encephalocele scan image can be picked up on ultrasound. Okay, this is the baby scalp, and then this is the swelling. This is the encephalocele. Okay, and this is spina bifida. Spina bifida associated with lemon sign, frontal bole scalloping, and this is the banana sign. Okay. So, with these images, you get a hang of it that neural tube defects are structural malformations that are picked up on ultrasound. So, targeted sonography is the investigation of choice to diagnose them, and anyways we are going for routine level 2 scan, targeted sonography for anomalies in pregnant women, and anencephaly is one anomaly which can be detected in the first trimester also. It can be detected as early as 10 weeks, but definitely so by 14 weeks. By 14 weeks, the skull should be visible, the biparietal diameter should be measurable. And one clue that, one clue about anencephaly is one may not be able to very clearly see these signs and all, but if a sonologist cannot visualize the biparietal diameter, that's a very big clue. कि क्या हो गया ये स्कल का ट्रांसवर्स, आई एम ट्राइंग टू फोकस द ट्रांसवर्स प्लेन, आई एम नॉट एबल टू measure the biparietal diameter, I've been trying for quite some time. That's a clue that this portion, this calvaria, this skull and this calvaria is not there. Okay, so you see here the components of the aneuploidy testing. This is all about prenatal aneuploidy testing. I will give you the key points to remember. Prenatal aneuploidy testing, I'll give you the key points to remember. First trimester mein, if we are going to go for screening, the screening test that we offer, first of all, it is offered to all women. Please remember that. What we offer will depend upon where we are with the pregnancy, right? So when you happen to see a woman in the first trimester, then you can go for first trimester combined screening. If you go for only the serum test, it is called as dual testing. Dual testing pehle karte the, we nahi karte. Dual testing is not very sensitive or specific. To increase the detection rate of the dual test, this nuchal translucency on transvaginal sonography was added. You can see here, we call this NT-NB scan, done between 11 to 14 weeks, right? This one, 11 weeks to 14 weeks. To be very precise, 13 weeks, 6 days. So this is the nasal bone, this white spot of nasal bone. It should be present. Nasal bone absent would be a soft marker. NT is this. See, in the first image, I showed you cystic hygroma. This is NT. This is NT, this nuchal translucency. NT, this nuchal translucency is being measured behind the nape of the neck. Okay. And NT more than or equal to 3 mm should be considered abnormal. Should be considered abnormal. Now, quadruple testing is done between 15 to 20 weeks. Okay. Remember also for INI-CET particularly high, what is elevated? Okay. High. HCG is high. HCG is high. Inhibin is high, rest all markers are low. Rest all markers are low when we have trisomy 21. When we have trisomy 21. Okay, HCG is high, inhibin is high, rest all markers are low. Right? So, quadruple testing. If we were to do only these three, beta HCG, maternal serum alpha fetoprotein, unconjugated estriol, then it would be triple test. अब मार्केट में हम quadruple ही ऑर्डर करते हैं. ट्रिपल क्या? ट्रिपल with triple test the detection rate is not as good. Quadruple test will give a better detection rate, right? And NIPT, yes, of course, if you look at it currently, NIPT at present gives the best detection rate at present overall, but it's expensive. It's expensive, it's very expensive, and anyways it can be done anytime beyond 10 weeks, and currently for it can be analyzed for trisomy 21, 13, 18, monosomy X. For these aneuploidies it can be used. Okay, and yes, Sunil, trisomy 18 all are low. Yes, trisomy 18, HCG low, PAP low, this is also low, this is also low, this is also low. Inhibin A is not included in the calculation, risk calculation for trisomy 18. Next question. Ultrasound is done in the first trimester for all of the following except. Straightforward question. Yes, ultrasound is done in first trimester for all of the following conditions. No, Shubhi, it is not specific for women more than 35 years. I told you that prenatal aneuploidy screening should be offered to all pregnant women. That is the recommendation. Okay. So, yes, we just saw for placental localization. That is your answer for determination of chorionicity. We can do it in the first trimester. For determination of chorionicity, best time would be 10 to 14 weeks. Okay. And then gestational age estimation. Done in the first trimester. Earlier it is done, the better it is. Okay, earlier it is done, the better it is. Aneuploidy screening, you just saw first trimester combined screening as well. Now look at these ultrasound images. Look at these ultrasound images. Make a note of these ultrasound images. Okay, so this is your uterus. This is your cavity, and this is the sac. Okay, it has got empty space here. So, this is fluid filled. Okay, gestational sac is fluid filled. So, this is a sac, anechoic center and white ring, single white ring. So, this is the intradecidual sign. This is the intradecidual sign. Intradecidual sign. Intradecidual sign. Okay, and this is basically showing a gestational sac. This is basically showing a gestational sac. This is very early sign, but it is not very suggestive of a true gestational sac. What is going to be suggestive of a true gestational sac is this double decidual sac sign, two concentric white lines. So, this is double decidual sac sign, and this is the earliest sign of intrauterine pregnancy. This is the earliest sign of intrauterine pregnancy. Okay. And then we have this. This is inside the gestational sac. You are able to see another sac. This is another sac. See, this one here is another sac. This is double bleb sign. One can see a fetal pole also. In this, one can see a fetal pole also. One can see the double bleb sign also. Double bleb sign meaning yolk sac inside the chorionic cavity, or yolk sac inside the gestational sac. Yolk sac inside the gestational sac, yolk sac inside the chorionic cavity. And later on, yes, you will see this. Can you see this? This is the outline of the uterus. This is the cavity. One can see this yolk sac, one can see this fetal pole, one will be able to see the cardiac activity, right. So, this is now, if this were a live scan, one would be able to see the cardiac activity also. If this were a live scan now, one would be able to see the cardiac activity also. So, remember these images, this can be image based spotters. And what is the image spotter here? If I tell you that this is being measured, see, if I demarcate that this is being measured, what is this being measured? CRL. This is measurement of CRL. This is best for gestational age assessment. Okay, it's seen in the first trimester up to, okay, best for gestational age estimation. So, these can be direct spotters. Next question. 32-year-old pregnant woman is undergoing routine prenatal ultrasound at 18 weeks. Ultrasound reveals that she is carrying twins. Further assessment confirmed that the twins share a single amniotic sac and a single fused placenta. Which of the following complications is most specific? A straightforward question. All you had to do is identify which type of twins they are talking about. There's single amniotic sac, single shared placenta, monochorionic, monoamniotic. Okay, so they may say that there is a single amniotic sac, or they may say that during scan that there is no intertwin membrane. They may describe it like this also. No intertwin membrane is there. Single fused placenta is there, no intertwin membrane is there. Now answer. बच्चे मोनोकोरियोनिक मोनोअम्नियोटिक में है, most specific to this type of twin pregnancy, which cannot happen in any other type, which cannot happen in monochorionic diamniotic or dichorionic diamniotic. The fact is that they are in the single amniotic sac. So this particular complication cannot happen if they are in two separate sacs, and that is cord entanglement. That is cord entanglement. Twin to twin transfusion syndrome can happen in monochorionic, monoamniotic also, but TTTS is usually more common in monochorionic diamniotic as compared to monochorionic monoamniotic, but it can happen in both. Selective fetal growth restrictions, preterm labor, they can happen in any of the any type of twin pregnancies. Okay, so straightforward. So please remember here, overall most common type of twins, DCDA, and overall most common type of twins, dizygotic, they are always DCDA. Okay, within 3 days of fertilization, if monozygotic twins divide, it can lead to dichorionic diamniotic type of twins. Between 4 to 8 days, monochorionic diamniotic, monochorionic monoamniotic, and conjoined. Okay, this is direct factual ratification what information. If you look at this here, now compare and scanned images. Look at this. Scan images, I want you to see. This is, they are having two separate placentas. They are in their two separate gestational sacs. If they are in two separate gestational sacs, they are dichorionic diamniotic. Obviously. Okay, twin number 2 in two separate gestational sacs seen in early pregnancy. Okay, there can be two separate placentas seen. That means one placenta anterior wall, other placenta posterior wall, let's say dichorionic diamniotic. Okay, now look at this. This is a single fused placenta. This is a single fused placenta. Okay, but doesn't mean, but there is no sharing of placenta. What is happening? Intertwin membrane mein dekho. What is happening? The chorion is dipping. Chorion is dipping in the intertwin membrane. So that is what we are seeing here. This is the placenta. That is what we are seeing here. This dipping in the intertwin membrane. This placental tissue, chorionic tissue. This is lambda sign. This is lambda sign. Twin peak sign. Dichorionic diamniotic. So there may be a single placenta that looks fused because it is fused actually, but there is no sharing of placenta. So lambda sign or twin peak sign. Okay, and then you look at this placenta, T sign, no dipping of chorion. Intertwin membrane is there, twin 1, twin 2. This is this one here, so thin intertwin membrane. See, this is T sign. Monochorionic diamniotic. Here no intertwin membrane, monochorionic monoamniotic, single fused placenta. During the scan, no intertwin membrane will be there. These are conjoined. Okay, so remember these images as well. Next question. 29-year-old pregnant woman, monochorionic diamniotic type of twins. Routine scan at 32, no significant difference in weight or amniotic fluid volume. Doppler study show difference between middle cerebral artery peak systolic velocity between the twins. Most likely diagnosis? Yes, most likely diagnosis. The only issue here is, see, there is no difference in weight. So it's not like one of the twins or both of the twins or either of the twins is getting growth restricted. This is not the answer. Twin reversed arterial perfusion is a cardiac twin. Okay, in which there is a single one twin and the other twin is just an appendage with no heart. So this is not that. Okay. Now in TTTS, बच्चे in TTTS, the stage 1 of TTTS is oligopolysequence. शुरुआत तो वहाँ से होगी ना. One twin has oligo, the other has polyhydroamnios. Amniotic fluid volume में कोई difference नहीं आया है. There is no difference in weight. It is not TTTS. What is the problem? Middle cerebral artery is for early detection of fetal anemia. One twin could get anemic. Anemic twin, that is the donor twin, will have raised MCA-PSV, and the recipient twin, right, will the polycythemic twin will have low MCA PSV. TAPS, twin anemia polycythemia sequence. Okay, fine. Now, next question. Which of the following is true regarding cervical cancer screening in low resource settings? Low resource settings we are saying, बच्चे low resource setting we are saying co-testing is HPV plus PAPS. For PAPS is always resource intensive. PAPS में infrastructure is needed, is more, pathologist is needed, automation भी ज़्यादा नहीं होती है, इसमें reporting चाहिए होती है. So co-testing, PAPS is not there. HPV DNA testing has to be done. If the resources are low, okay, nowadays self-testing kits of HPV are also available. But these kits in India currently, I have not found them available. Okay, you can go buy it in the chemist. Okay, sometimes yes, when studies are being conducted, when theses are being made, you know, we kind of acquire them from the known suppliers and everything. That kind of recruitment is done. When the government wants to conduct a study, pilot study, they recruit these self-testing HPV DNA kits, but they are not widely available even in the peripheral healthcare centers. The utility of self-testing HPV DNA kits is basically in self-testing, so that the health worker can provide the kits to the woman, and you know, they can do it at home, collect the sample, give it to the health worker can bring it, because many times women don't turn up for screening. That's the benefit. Okay, so in low resource setting, please remember what is the WHO says what is the priority screening age group. Priority screening age group is 30 to 49 years. When I have limited resources, okay, I have this age group 30 to 49 years, and I have this huge age group from 25 year onward. Why would I want to do HPV DNA starting at age 25 then? So then this is not right. HPV DNA testing every 5 years starting at age 30, right? And low resource setting, VIA can also be done. VIA option नहीं है यहाँ पे. Yes, Shubhi, VIA is definitely an option. VIA यहाँ होता, VIA would have been the best choice answer, but visual inspection of acetic acid दिया नहीं है. आज के डेट में लो रिसोर्स सेटिंग में इन आर PHC CSCs विजुअल इंस्पेक्शन विद एसिटिक एसिड हम कर रहे हैं. WHO लेकिन प्रमोट करता है कि भाई HPV DNA टेस्टिंग शुड बी मेड अवेलेबल. तो इस पे ये क्वेश्चन आया था प्रीवियस ईयर एग्जाम में, व्हेन दैट अपडेट हैड कम, एंड HPV DNA टेस्टिंग एवरी 5 years स्टार्टिंग एट एज 30 इज द बेस्ट चॉइस आंसर. लुक एट दिस WHO अपडेट. दे आर सेइंग HPV DNA टेस्टिंग एज प्राइमरी स्क्रीनिंग टेस्ट. हम लोग भी इसी की तरफ जा रहे हैं अभी. ओके, एवरी 5 to 10 years. WHO तो ये भी कह रहा है कि 10 साल में कर लो. अगर 10 साल में करा, माने के WHO सेइंग के एक वुमन की एज 35 years में कर लो, एक 45 years में कर लो. So what will happen is that at least every woman will get screened twice in her lifetime, right? So that is what the utility of WHO screening approaches is. Okay, ठीक है. But VIA अगर करना है low resource setting में, this is also for low resource. This is also for low resource. Then VIA needs to be repeated every 3 years. Then VIA needs to be repeated every 3 years. So that is why, you know, फिर वो भी होता है कि the point is that for VIA visual inspection या तो फिर वो कैंप करने पड़ेंगे, या फिर it will be an opportunistic screening method where patient has come to the OPD for some other purpose and we are screening all the women with VIA. So that kind of a thing will have to be done, and then it has to be repeated every 3 years. So if you think about it on a long-term strategy based level, HPV DNA testing will turn out to be more effective because we're doing it at every 5 year, and WHO is saying you can even extend till 10 years in the and priority age group mein, right? So that is why. Next question. In a patient with atypical glandular cells on pap smear, when is endometrial sampling recommended? So, we had a question on atypical glandular cells in INI-CET, but I have changed the question. I have made a different question out of it. In which patient with atypical glandular cells on pap smear, endometrial sampling is recommended? BBB. Very good. Very good. So, atypical glandular cells mean they could be coming from the endocervix, they could be coming from the endometrium also. So, basically, yes, atypical glandular cells, we need colposcopy, but along with colposcopy, we need ECC. And if the woman is more than or equal to 35 years, then we also add endometrial aspiration to the evaluation. But common sense says that if there is a suspicion of endometrial pathology, one would like to add endometrial aspiration also to the evaluation. So, somebody with regular cycles does not deserve an endometrial sampling. Somebody who is asymptomatic does not deserve endometrial sampling. Somebody who is on hormonal contraception and anyway she is not having any abnormal bleeding pattern does not necessarily deserve endometrial sampling. Oral contraceptive pills are actually protective against endometrial pathology any which ways. So, 32-year-old intermenstrual bleeding is pointing towards the possibility of endometrial pathology. So, then we go for, then we can add endometrial sampling during the evaluation process along with colposcopy plus ECC. Okay. So, B is your answer. Next question. Now, I have 1, 2, 3 amenorrhea questions for you people. INI-CET amenorrhea mein question to most of the time comes. Now, a 15-year-old girl presents to clinic with concerns about not having started her menstrual period. So, primary amenorrhea ka context set ho gaya, right? What is the best investigation in the workup? Should I do a hormone profile? Should I go for a karyotype? Should I go for MRI? Should I go for examination of the vaginal canal? These are the options I have to choose from. Now, read through. Yes, urine pregnancy test was negative. Physical examination shows normal secondary sexual characteristics. The moment you read normal secondary sexual characteristics, that means breast development must be present. Moment you read breast development present, it means that obviously secondary sexual characteristics will involve pubic hair also. Pubic hair also must be present. So, breast development present. So, this is basically no estrogen deficiency. There is no estrogen deficiency. Absent uterus is there. If there is absent uterus, there is two possibilities: Mullerian agenesis or androgen insensitivity syndrome. Alright. So, now what you want to do? I want to, most of you are saying B. Most of you are saying B, yes. If I am not expecting any estrogen deficiency, serum FSH, LH, TSH, prolactin levels are not necessary. These are more important when there are signs and symptoms of estrogen deficiency. There is absent breast development, height is also low and everything. So, yes, then FSH, LH, TSH, prolactin levels makes more sense. That would where it will be more helpful. So, for now, this will not be the best investigation. Investigation wise, we do the full profile, but for now, for choosing this in this question, it will not be the best investigation. Examination of vaginal canal. Bhaiya, in a primary amenorrhea, like in a young girl, examination of vaginal canal, I mean, not very important, already ultrasound is showing absent uterus. So, this is not right. And obviously, when there is, when you have to think about the possibility of cryptomenorrhea is there, when you're thinking about transverse vaginal septum or imperforate hymen, where uterus is present, where collection is there inside, there it makes sense. Here it doesn't make sense. So, now we have to seek between karyotype, MRI. Mullerian agenesis, androgen insensitivity syndrome. One should always, ideally one should have a karyotypic analysis because, yes, ideally one should have a karyotypic analysis, okay. So, karyotype analysis has to be done, and MRI pelvis can be done in case MRI pelvis will not, add any new information. Uterus is already absent. MRI pelvis would be better, let's say, in case there is in case Mullerian agenesis has been diagnosed and one wants to look for associated renal anomalies. And most of the times ultrasound is good enough in picking that up. Sometimes there are complicated anomalies and doubts are raised on ultrasound. Then one can think of MRI pelvis to rule out complex genitourinary anomalies. I mean, if renal agenesis has to be seen, it can be seen on ultrasound also as a part of MRKH. So, MRI pelvis may be needed at a later point in time. So, for now it is not needed. Okay. Alright, now the trick for these questions is elimination. There is no other trick, because I have also tried, whenever I see your questions in exam, I solve them for myself, I solve them while doing these discussions with you people. I eliminate. There is no way this whole flowchart is muggable. Aisa nahi hai. It doesn't happen. You have to understand the logic. So, the logic says when there is delayed puberty, primary amenorrhea, absence menses by 15 years of age, by 13 years of age, in the absence of secondary sexual characteristics, and by 15 years of age in the presence of secondary sexual characteristics, focus on what they are telling you about the breast development. At least note this, that first you should be looking at what they are telling you about the breast development. If breast development is present, that means there is no estrogen deficiency. That is what it means. That means nothing is wrong with the ovaries, nothing is wrong with the pituitary hypothalamus. That means that the HPO axis must be normal. That is why estrogen is there to cause breast development. So, problem must be with the uterus. So, if uterus is present, history of cryptomenorrhea, hidden menses is there, then bulge at the introitus is there, your diagnosis is imperforate hymen. And the treatment is cruciate incision over the hymen and let it drain. Cruciate incision over the hymen and let it drain. If the uterus is absent, if they tell you that the uterus is absent, the information that the uterus is absent, you have to look in the question. They may tell you on clinical examination, they may tell you on per rectal examination, the cervix is not felt. They may tell you on per rectal examination, cervix is not felt. They may tell you there is just a blind vaginal pouch on clinical examination. These are clues that the uterus is absent. They may tell you scan was done, uterus is absent. So, when the uterus is absent, it's Mullerian agenesis or complete androgen insensitivity syndrome. Look out for these extra information if it is provided. Gonads, ovaries, gonads, testes. Serum testosterone, normal range. Serum testosterone elevated in the male range. Serum testosterone elevated in the normal female range. Okay. Karyotype will help us find the definitive answer. Karyotype will help us find the definitive answer. Now, if there is delayed puberty and absent breast development, if there is delayed puberty and absent breast development, if breast development has not started, that means there is estrogen deficiency. Why is there estrogen deficiency? Maybe ovaries are the problem, or maybe ovaries are okay and they are not getting a signal from above. If ovaries are the problem, hypergonadotropic hypogonadism, FSH will be high. Then in that situation, you should go ahead for a karyotype. You should go ahead and do a karyotype. Okay, short height, streak ovaries, if they are mentioning, only situation where there will be a short height and FSH high. Here, streak ovaries, very characteristic. Turner syndrome. Tall, streak gonads, uterus present, these are other types of gonadal dysgenesis. Other types of gonadal dysgenesis. Turner syndrome is also gonadal dysgenesis. Other types of gonadal dysgenesis can be 46XX gonadal dysgenesis, can be 46XY gonadal dysgenesis, which is Swyer syndrome. To know for sure, one would need the karyotype. To know for sure, one would need the karyotype. So, if you understand the logic, you can understand here, if the FSH is high, there is hypergonadotropic hypogonadism. They can ask you the next step. You are thinking about the possibility of gonadal dysgenesis. Which gonadal dysgenesis? You will know for sure when you go for a karyotype. FSH is low, hypogonadotropic hypogonadism. FSH low, tall plus anosmia, Coleman syndrome. FSH low, hypogonadotropic hypogonadism. One should always rule out a CNS tumor, right? One should always rule out a CNS tumor also. One should always rule out a CNS tumor also. This can be craniopharyngioma. In the context of primary amenorrhea, craniopharyngioma is most common. And once everything else is ruled out. So please, when you have estrogen deficiency, ideally we have to go for the entire hormonal profile, LH, FSH, estradiol, TSH, prolactin, all of this, the entire hormonal profile has to be done, right? And once we have ruled out everything, a diagnosis of exclusion, short, height, other causes have been ruled out, FSH is in the low normal range, this could be constitutional, which becomes a diagnosis of exclusion. Okay. So when I go through the flow chart, you understand the logic behind the flow chart. While attempting questions, if you are hung up on trying to recall the flow chart like in front of your eyes magically appear that you will know exactly, no, it will not happen. For these questions, you have to look at the keywords and eliminate options. That's why I have more questions for you. Look at this here. If you understand the logic, any permutation, combination of options you can answer. 16-year-old girl presents with primary amenorrhea, breast development, Tanner stage 1 and pubic hair present. Okay, so breast development is Tanner stage 1. Breast development is not starting. Okay, so estrogen deficiency is there. Estrogen deficiency is definitely there. Uterus is documented to be present and she is found to be hypertensive. FSH, LH are elevated, karyotype is 46X, most likely diagnosis. I have purposely not underlined one more keyword for you. I want it to come from you. So, uterus is present. It's not androgen insensitivity syndrome, karyotype is 46XY. 21 alpha hydroxylase deficiency, congenital adrenal hyperplasia. There is virilization in this. It can be associated with precocious puberty, heterosexual precocious puberty. Okay, so here that is not happening. It's not this. Okay, and now we have hypertensive. Excellent, right? So this could be gonadal dysgenesis. It could still be gonadal dysgenesis. They are not mentioning anything about the gonads. Okay. See, when the ovaries are unstimulated, no, ovaries ka generally बहुत difficult होता है. It is very difficult on scans to comment. Especially in such young girls, it is difficult to comment whether they are actually completely entirely dysgenetic or there are some remaining follicles inside. Okay, it's difficult to say. So mostly hormone analysis helps. So it could be 46XX gonadal dysgenesis also. So a type of gonadal dysgenesis could be there. But hypertension, where is hypertension? Hypertension is going in favor of 17 alpha hydroxylase deficiency. So with 17 alpha hydroxylase deficiency, this enzyme is needed for androgen production. Androgens are also produced in the adrenal glands. This is a rare form of congenital adrenal gland hyperplasia. Okay, so now androgens are not getting formed, no androgens, therefore no estrogens. Okay, no androgens, therefore no estrogens, because estrogens are the raw material for androgens, right? But if in the adrenal gland, androgen formation is not happening, so the raw materials are instead getting diverted towards mineralocorticoids and glucocorticoids. So increased mineralocorticoids, cortisone, deoxycortisone, that is causing hypertension in these patients. So this is how questions can be framed, because congenital adrenal hyperplasia is something that gynae mein you do not read in too much detail. You read much of it in pediatrics, right? और अगर INI-CET में इस तरह के क्वेश्चंस बनाते हैं वो इस एंजाइम डेफिशिएंसीज वाले which they tend to make from time to time, then answer has to be based on logic and eliminating options. Okay, now next question. Most likely cause, again enzyme deficiencies are given to you. Now 14-year-old girl is brought by her mother with complaint of absent breast development, not having started menses. Girl is tall, well developed, deepening of voice, clitoromegaly and bilateral inguinal masses. Pubic hair are absent, uterus cannot be felt on rectal examination. Uterus absent, serum testosterone are markedly elevated. Serum testosterone are markedly elevated. Okay, so one clue that I want you to remember and look at, if there is a girl, young girl, born and brought up girl coming with primary amenorrhea and you happen to see inguinal masses, these are almost always testes. These are almost always testes, undescended testes, maybe normal testes or maybe dysgenetic testes. That is out of the question, but almost always testes. In this question, they may mention 46XY karyotype to you as well. Okay, now uterus is absent and your deepening of voice is also there. Pubic hair are absent. Pubic hair are absent. Right. So, pubic hair absent. Androgen insensitivity you are saying, but if it is androgen insensitivity syndrome, which is androgen receptor deficiency you are saying, if it is androgen receptor deficiency, then breast development should be normal, no? Breast development should be normal. Agreed on this? Breast development should be normal then. Androgen insensitivity syndrome. The excess testosterone gets aromatized to androgens in the periphery. That is why women with androgen insensitivity syndrome, they have well developed breast. When we are talking about complete androgen insensitivity syndrome. So, this is not the answer. 21 hydroxylase deficiency, 46XX female would be there. There can be virilization in this also, but 46XX female will be there. Okay, fine. And the gonads will be ovary, so they will not be in the inguinal masses. There will be no inguinal masses. Okay, so the gonads will be ovaries. I am saying in this question, gonads are almost always testes in this situation when there is inguinal masses. When there is inguinal masses. So, 21 hydroxylase deficiency is also eliminated. In 17 alpha hydroxylase deficiency, what was happening? If a male fetus is there, if a male, genetically male fetus is there, these are development of sexual disorders. Such questions when asked in INI-CET, if you do not have the basics of development of sexual disorders clear, ये question attempt नहीं हो सकता है, फिर इसको छोड़ के आगे बढ़ जाना. But the basics of development of sexual disorders has to be clear. So, the situation here is that of a genetically male fetus, but who turned out to be phenotypically female, born and brought up as a female, and then picked up and then diagnosed with amenorrhea. Right. So, 17 alpha hydroxylase deficiency में androgen deficiency है. If there is androgen deficiency, androgen related changes like deepening of voice and clitoromegaly, that will not come. That will not be there because they will have androgen deficiency. By elimination, answer is 5 alpha reductase deficiency. By elimination, answer is 5 alpha reductase deficiency. Okay. Now I'll give you a flow chart also. Let's recall this flow chart. Young girl with primary amenorrhea, inguinal or labial mass, they may mention karyotype 46XY. If uterus is present, pubic hair is present. If uterus is present, there is only one situation, Swyer syndrome. One situation, Swyer syndrome should be your answer. 46XY gonadal dysgenesis. but pubic hair absent, you are saying. Deepening of voice, right? These are like, deepening of voice, muscle mass, these are directly testosterone related changes, okay? And your pubic hair and pubic hair development, these are mainly related to your DHT, 5-DHT, that is which is causing growth in these sexual areas, right? So that's why pubic hair may be absent also, right? So pubic hair पे से ज़्यादा मैंने focus भी नहीं किया. I mainly answered by eliminating, not focusing too much on pubic hair at all. Got it? Now, if your uterus is absent, and well-developed breast and pubic hair are absent are given, it is complete androgen insensitivity syndrome. If the breast development is absent and there is no virilization, it's androgen synthesis deficiency. Example is 17 alpha hydroxylase deficiency, and then hypertension may also be there. Okay. If breast development is absent, virilization is present. If breast development is absent, virilization is present, like we saw in the previous question. Virilization will be testosterone related changes. There may be clitoromegaly, there may be deepening of voice, there may be male pattern muscle mass and everything, right? So that sort of virilization, male pubertal changes are coming. Then there are two possibilities, 5-alpha reductase deficiency and partial androgen insensitivity syndrome. In 5-alpha reductase deficiency, serum testosterone and serum DHT value, this ratio is elevated in favor of testosterone. Partial, this ratio is normal. If they want you to differentiate between these two conditions, they will have to mention this, otherwise you cannot differentiate. Okay. So this is your flow chart. All right. Clear on this? Clear on this? अब इस तरीके के इस flow chart को ध्यान में रखते हुए you read through the flow chart, understand the logic, and if you get more questions like this, there are more questions, similar questions in my, and in every lecture of mine, I discuss questions on primary amenorrhea. So different questions have been discussed with different permutation combination of options, but the same logic becomes applicable, okay? That doesn't change. Now identify the contraceptive shown in the image given below. Yes, image. This is basically for identification purposes. This is Cyana Press, 104 milligrams of subcutaneous injection it is. Cyana Press. Cyana Press is the name, marketing name from WHO. WHO markets it like this. But in the government of India, it is Antara Subcute. 104 milligram DMPA injectable. Every 3 monthly, Similarly, okay, Government of India ने बोला था कि this would be made freely available, but अब again on paper and in field, in practice different. So ये Government of India कहती तो है that it should be freely available under the Health and Family Welfare Scheme. Anyways, so this is injectable DMPA, the subcute form, okay? So good for self-administration, good for administration by ASHA workers and lay healthcare workers, okay? Fine. Yes, time period before and after. Antara ka dose jo IM, when you give Antara, the IM, injectable DM, IM is 150 milligram. IM is 150 milligram. This is subcute is 104 milligrams. Okay. Yes. When we say Antara, IM, which is injectable DMPA, for IM route it is 150 milligram. Dose is 150 milligram every 3 months. Yes. And before after wahi hai. Yes. 2 weeks before the due date, if this is the due date, then 2 weeks, 4 weeks. 2 weeks and 4 weeks. इसके बीच में लगा सकते हैं. This is the safe zone. This is the safe zone. Reversal of contraception, meaning after stopping the injection, there is a delay in fertility. Only in injectable DMP is there a delay in fertility. On an average, that delay is about 12 months. 12 months on an average. Next question. Which of the following is an absolute contraindication for the insertion of this device? This device is Copati. Absolute contraindication. Contraindication, Sachinandan, absolute contraindication. Absolute contraindication. I am very quick at seeing your responses. Absolute contraindication. Yes, trophoblastic disease. Trophoblastic disease, that is why when we are following up women after molar pregnancy evacuation, when we are following up patients, beta HCG follow-up we are doing, at that time, Copati or any intrauterine device for that matter, nothing is put inside the uterus, okay, Copati is not put, there can be chances of, what we say, perforation of the uterus, okay, increased chance of perforation of the uterus, then at that time OC pills are preferred. So menstruation, we generally don't prefer to put Copati in a menstruating woman, because obviously it's uncomfortable, patient is bleeding, she's having dysmenorrhea at that time, not very receptive time for a woman to, you know, put in Copati, but it's not like it's contraindicated, it can be put. Right. Immediately after delivery, yes, we do it, and ruptured condom during intercourse, yes. So, as an emergency contraceptive, it can be used. Immediately after delivery, please mark my words, when we say postpartum insertion, we are meaning within 48 hours, postpartum is the time when we can introduce it. And ideally, you know, the opportunity immediately after delivery would first come in the LR, okay. So if we get that opportunity, that is a very good time, because patient is also receptive, she is on table, and immediately after delivery of the placenta, we can introduce very safely. The external os is also patulous, so it's very conveniently and easy insertion can be done. When we say post placental insertion, okay, within 10 minutes of placental delivery, but it should not interfere with the active management of third stage of labor, okay. So this, if we get this opportunity, this would be the ideal time. Convenient, patient receptive, easy to do, okay. Opportunity missed, then yes, postpartum insertion within 48 hours postpartum can be done. So before discharging from the hospital, it can be done. If not now, then after 6 weeks. Then after 6 weeks, just like any other interval insertion after 6 weeks postpartum. Now next question. 31-year-old woman with inability to conceive for past 1.5 years has been advised to undergo hysterosalpingography for evaluation of tubal patency. She has had 3 prior first trimester abortions. Curettage was done each time. So what do we see? Context of infertility, history of abortions, curettage, pelvic reports normal, cycle regular, scanty periods. These are your clues. Given her history, HSG is most likely to show excellent intrauterine synechia. Alright, so all of the points in the history are supporting the diagnosis of intrauterine synechia, that is Asherman syndrome. Okay. Now in this situation, if they had asked you what is, let's say, Asherman syndrome is detected, then the best for diagnosis of Asherman syndrome will be hysteroscopy, and it will confirm the diagnosis also. We can go for hysteroscopic adhesiolysis also. Next question. A couple is being evaluated for infertility. Most likely diagnosis they are asking you, they are showing you the image also. There is history of being PID in the past, history is there. So that is pointing towards tubal factor. HSG is showing this distal tubal block. Right. Now distal tubal block, here would be hydrosalpinx. Here would be hydrosalpinx, retort shaped tubes, right? And obviously it will be hydrosalpinx because now this is a chronic sequelae of PID and tubal damage. Fluid filled tubes, hydrosalpinx. Okay, endometriosis will not show any tube. Endometriosis is pelvic disease. It is not going to show you blocked tubes or damaged tubes from the inside like this. So yes, this is retort shaped tubes. Tobacco pouch appearance, yes, tobacco pouch appearance is also there. It can be called as tobacco pouch appearance. This is not tube ovarian mass, this is not Asherman syndrome, this is hydrosalpinx, and along with that there is bilateral tubal block. Okay, what is this image? What is this image? This is showing you the dye not coming out of the cornua. This is cornual block. This is bilateral cornual block. This is bilateral cornual block. So HSG can point towards blockage and it can be used as a screening test. It can be used as a screening test, right? So whenever you have abnormal HSG showing blocked tubes, the next step is laparoscopy, preferably with a hysteroscopy. Next step is laparoscopy, preferably with hysteroscopy. Not hysteroscopy alone. If hysteroscopy cannot be done, is not available, that is another matter. Preferably with hysteroscopy, but yes, laparoscopy. What do we do in laparoscopy? We want to see for laparoscopic chromoperturbation. See this. This is laparoscopic chromoperturbation being done in this image, and we are seeing, see, this is the dilated tube, hydrosalpinx. This is hydrosalpinx on transvaginal sonography. Fluid filled dilated tube. Because it is filled with fluid, look at these adhesions, small flimsy adhesions, damaged tube adhesions inside, they are so clearly visible. The reason they are visible is that it is a clear fluid filled tube. This is what we see as the cogwheel sign. Cogwheel sign. This is hydrosalpinx. So this patient came to, you know what, this patient was being evaluated for infertility. Ultrasound had shown this image. Okay. And when we did the laparoscopy, diagnostic laparoscopy, these were the images. So this is the blue dye. She had hydrosalpinx on one side and the other side tube was open and the dye was collecting. So at least one tube was open for her. And laparoscopic chromoperturbation also helps. Why? Because it will help us see the condition of the tubes. Like we can see hydrosalpinx. In this case, we can see a beaded tube. You know, look at the condition of this tube. You can see the beaded, thickened tube, and we can see this white tubercle. When we see this white tubercle on the tube, on the serosa of the tube, it can be multiple white tubercles. The serosal lining of the tube, the serosal lining of the uterus can be studded with these mealy tubercles. This is genital tuberculosis. This is genital tuberculosis image. Of course, I will take a biopsy. Of course, I will take a biopsy. I will send it for histopath evaluation in which I may be able to see granuloma, and I will try to isolate the tubercle bacilli. So, diagnosis of tuberculosis will be done in the same manner or isolation of tubercle bacilli will be done in the same manner as it is done in any other patient. So, culture, AFB, BACTAC and all that. The only thing is the tissue will be taken out or tissue biopsy will be done from the involved sites. Okay, so keep that in mind. Now, next question. A young woman is being evaluated for infertility, severe dysmenorrhea is there, dyspareunia is there. Classic triad, infertility, dyspareunia and dysmenorrhea. Uterus retroverted, tender nodularity, posterior vaginal fornix में. Mass is there, 5 centimeter, image is shown. What do we see in the image? Image has to be analyzed in the context of the clinical profile. Clinical profile, you could say that this is a solid ovarian mass. Now, I will say in the clinical context, this is ground glass appearance. In this clinical context, this is ground glass appearance. CA125 levels are raised, fine. CA125 levels in reproductive age group are very non-specific markers. Any factor with any condition with peritoneal inflammation can lead to elevated CA125 levels. So, what is the likely diagnosis? Very good, endometriosis is your answer. So again, similar kind of profiles may be given to you. Additional images may be given. For this patient, laparoscopy image was this. This is again endometriosis. This is endometrioma, chocolate cyst. Okay. Endometrioma, chocolate cyst, these are again endometriotic deposits, right? They can be superficial, subtle, flame-like deposits. There can be these deposits. These are like the powder burn deposits, blackish nodules, fresh deposits, fibrosis around the deposits, right? This is the top fundus of the uterus that we are seeing, and this is the pelvic peritoneum where these deposits are present. Yes, gunpowder like appearance also. And Mohammed Sohail, yes, you can ask me the question. Please put it on the chat box. I am listening. Why free fluid in POD points towards ectopic pregnancy? Bleeding. Ectopic may, there can be two possibilities, tubal rupture or tubal abortion. That means ectopic aborting out of the fimbrial end. All in all, in that process, bleeding will be there. That bleeding can collect in the pelvis. That will be appreciated as free fluid in the pouch of Douglas. Whether the patient is stable, unstable will depend upon how much blood loss has happened. Okay. Next images. Next set of images I want you to remember, these are dermoid cyst. Spotters, these are generally, they can be asked as spotters, dermoid cyst. Okay, so this is dermoid cyst on gross examination. This is where the solid nodule is there, where teeth, cartilage, and from where hair is growing all inside, cheesy material inside. You can see the sticky, greenish, yellowish, cheesy material and hair. This is the Rokitansky protuberance. Okay. Dermoid cyst is what we call as mature cystic teratoma. Mature cystic teratoma. And look at this image here. This is the ovarian mass. Okay. This is the solid nodule, hyperechoic white area, solid nodule. Okay. And this white dots and dashes. This is dash and dot appearance. Dash and dot appearance. Again, very characteristic of dermoid cyst. And here, look at this. Tip of iceberg sign, solid nodule and everything inside hidden, posterior acoustic shadowing. Okay, so this is the tip of iceberg sign. Tip of iceberg sign. Very typical of dermoid cyst, Dermoid cyst is one cyst which diagnosis can be made on your ultrasound itself. So that is why these are very typical images, very classic images, and can be put as spotters. Okay. Next question. An 18-year-old girl presents with abdominopelvic lump which on ultrasound evaluation is found to be solid cystic ovarian mass measuring 10 centimeter. 18-year-old girl. Raise blood flow inside the mass on Doppler. Look at this mass now. This is the entire ovarian mass. Okay, part of the mass we are not seeing here. Cystic area, solid area, septations inside the solid areas also, solid cystic mass, a lot of solid area, a lot of vascularity, particularly inside the solid area. These are all going in favor of possibility of malignancy. Okay. And an 18-year-old girl, a young girl presenting with an adnexal mass with a solid cystic ovarian mass, there is more likely probability of a germ cell cancer. This is most likely a germ cell cancer. Okay. Now, the diagnosis of malignancy for sure or not will only be made after the mass is removed and I'll have a final histopath, right. But I can send what? Tumor markers. Why do I want to send tumor markers? If the tumor markers are negative, will I not operate on this mass? No. The clinical suspicion is there, the ultrasound suspicion is there, I will still operate on the mass, but tumor markers are being sent for a purpose, so that when they are found to be elevated in the beginning, I have something to follow up later on. That is the entire utility of tumor markers. Tumor markers are never diagnostic. You read cancers in surgery also. So tumor markers are only done so that after surgery, after definitive treatment of any kind, these tumor markers can be followed up. So that is the utility, and obviously they have to be done prior to doing any intervention, isn't it? So I will like to send, okay, basic epithelial ke liye to I will send CA-125, but if you look at the combination of tumor markers, I want to include LDH, because dysgerminoma is the most common germ cell cancer. So if you look at the tumor marker profile, then in the first option LDH is not included. So that's, I don't pick that. I want LDH. I can avoid CEA because CEA is for mucinous histology, so I can avoid that. But I do want this LDH included. This is the exact PYQ that was asked. Okay, diagnostic laparoscopy. First of all, such patients with the suspicion of ovarian cancer have to be operated by oncology team after full metastatic workup. So it will not be like a diagnostic laparoscopy with a clinical suspicion of or clinical or radiological suspicion of malignancy. So this is out. And ultrasound guided FNAC, no. Because epithelial ovarian cancers, or ovarian cancers for that matter, they spread by tumor exfoliation, particularly epithelial ovarian cancers, right? So anyways, I have to do surgical staging for ovarian cancer patients, right? So please understand here that there is a potential that if we go for ultrasound guided FNAC, then we have, breached the capsule, and then from there, tumor cells can exfoliate and potentially spread along peritoneal surfaces. So initially maybe it was not just limited to the ovaries, and because of some intervention it may spread. So we don't want that. So ultrasound guided FNAC is something also that is not something that is routine in ovarian cancer evaluation patients. So this is out. So right now the most appropriate next step is sending the tumor profile. Okay. And Mohammed Suhail, CA-125 is a very good marker for epithelial ovarian malignancy. It has more utility in postmenopausal women because it has more utility in postmenopausal women. Why? Because for reproductive age group women, it is a very non-specific marker. Okay. Now, let's have a look at this question. Let's have a look at this question. A 45-year-old multiparous woman, obese and hypertensive, complained of heavy menstrual bleeding over past 1 year. TVS shows a small 3 centimeter intramural fibroid. ET is 10 mm. What is the next step in her evaluation? Yes? What is the next step in her evaluation? Most of you are choosing option number A as the answer. This is a very ये हमेशा आता है in some form or the other. The favorite question है ये, right? So this should not be wrong, okay? And instead of fractional curettage, it is very simple. No, go for the easy procedure. Endometrial aspiration can be done in the OPD, right? So we need some sort of endometrial sampling. How we sample? Endometrial aspiration can be done as an office-based procedure. So even though there is a small intramural fibroid, but such a small intramural fibroid may not be the explanation of her heavy menstrual bleeding. Look at her age. Obese, hypertensive, there is a very likely possibility that we may find endometrial hyperplasia or cancer, and then the management will change accordingly. So first perform endometrial aspiration. Hysteroscopy, not right now, and not proceeding with hysterectomy or myomectomy either. Okay. So option B I did not choose, Mohammed, because hysteroscopy is invasive. Hysteroscopy is invasive, unnecessary. So first line, next step should be endometrial aspiration. which can be done in the office-based endometrial sampling. Okay. Now, AUB in reproductive age group, think about the Palm-Cohen approach. Think about the Palm-Cohen system. Okay, Palm-Cohen system. According to this system, structural causes are there, non-structural causes are there. You see, the first line investigation has to be, the first line investigation is usually transvaginal sonography. Please remember, rule out pregnancy also. Don't forget to rule out pregnancy. And first line investigation is transvaginal sonography. Structural cause in itself means that there is some evidence on transvaginal sonography or there is some evidence on histopathology. That is what is structural cause mean. Non-structural causes will be this coagulopathy, ovulatory dysfunction and all, right. So, when we evaluate AUB, we have to look at the history, we have to look at the examination findings, we have to start with the basic first line TVS, and we also have to do endometrial aspiration, because malignancy can be a structural cause. This malignancy can be cervical malignancy also, it can be endometrial malignancy or hyperplasia also, everything in this. Okay. So, indication for endometrial aspiration when we are talking about reproductive age group women, if the ET is more than or equal to 12 mm, okay, and it has to be done if the age is more than 40 years. Okay. It can be done in younger women also if there is multiple risk factors for endometrial cancer or after failed medical management. One should always go for endometrial aspiration to see if one is missing out on some malignancy or hyperplasia. Indication of hysteroscopy would be strong clinical suspicion of intracavitary lesion. Now, when will I strongly suspect intracavitary lesion? I will strongly suspect intracavitary lesion when a patient is complaining of persistent intermenstrual bleeding, a very specific complaint, persistent intermenstrual bleeding, or the symptoms are persisting even after a normal endometrial aspiration. Because endometrial aspiration we have done blindly. Okay, we did in the OPD, we did blindly. It is quite possible that maybe some areas of the endometrial cavity got missed in the sampling process or in the evaluation process, right. So, if the woman is saying of persistent intermenstrual bleeding or persistent symptoms even after normal endometrial aspiration, these two, most importantly, these two are going to be strong, are going to be the pointers towards a strong clinical suspicion of intracavitary lesion. Now, look at these images, look at these images, okay, look at these images. This is image on the left, fibroid, okay, and this is adenomyosis, this is adenomyosis. So, you can see in adenomyosis you have a uniformly enlarged globular uterus, and on cut section you are not seeing any any demarcated tumor or a leiomyoma as you see here, as you see here. This is the leiomyoma, this is the leiomyoma, this one here, this one here, and on cut section you have this characteristic world appearance, characteristic world appearance. Now, I have put the gross images so that you can understand the ultrasound image also. So, initial investigation TVS should be good enough to differentiate between fibroid versus adenomyosis. Should be good enough to differentiate. Look at this. This is the outline of the uterus, okay. This is the endometrial lining. Where the endometrium is ending, where the myometrium is beginning, it is very difficult to tell. Posterior wall is thickened more, okay. These black dots that you can see, these black dots that you can see, this one here, okay, these are basically myometrial cysts, and this like the rays of the sun, like the blinds that we see on the windows, okay, this is Venetian blind appearance, right. So, this is adenomyosis, this is adenomyosis. Intermenstrual bleeding is that she is having regular periods, but anytime in between the months she can have bleeding here and there. Okay, so that is intermenstrual bleeding, bleeding superimposed on a normal menstrual cycle, and it can come at predictable events or sometimes absolutely unpredictable. So, this is adenomyosis, this is adenomyosis scan image, and you can see here, compare here, compare here. Look at this, this is the outline of the uterus, this is the cavity, This is the cavity, and this is the well-defined, clearly well-defined heterogeneous appearance. Can you see? This is the fibroid. And I can see on the image itself that this is an intramural fibroid. It is an intramural fibroid. Intramural fibroid. Okay. Now look at these two images. There are three images actually. So look at this image here. Look at this image here. Now MRI is not always needed to make the diagnosis of fibroid. But in this particular patient, we did an MRI because we were planning for a myomectomy, and this was a hugely enlarged uterus. This is the uterus. Okay, this is the cavity. There is a fibroid here, here posteriorly, studded with fibroids, huge fibroid, and we needed very precise information on the location of the fibroid, how many fibroids are there, because a myomectomy surgery was being planned. So MRI is not always necessary to make the diagnosis of a fibroid. Please remember that. MRI, if needed, will be done. So this is fibroid MRI image spotter. Image here, look at this. Junctional zone thickness. We see the junctional zone thickness on MRI increased more than 12 mm. It is diagnostic of adenomyosis. This is adenomyosis. In this image, we are seeing the junctional zone thickness. Okay, this is the outline of the uterus. This is the cavity, and this is the inner myometrium, junctional zone thickness. Okay, this is adenomyosis. And if you look at this here, this is another adenomyosis. This thin white line that you are seeing, thin white line, this is endometrium. This is the junctional zone thickness which is increased. Okay, you are seeing these adenomyotic deposits. Adenomyosis is endometrial glands and stroma deep inside the myometrium. This is what myometrial cysts are. On scan, they look at on scan they look as black spaces. Okay, myometrial cysts we call it. These same myometrial cysts on MRI look as white dots, hyperintense signals. These white dots, hyperintense signals, are myometrial cysts which can be appreciated on MRI also. So this MRI image has myometrial cysts also, these white dots, hyperintense signals on MRI, and this one doesn't have that many, not showing that many myometrial cysts, but showing definitely increased junctional zone thickness. So both of these are adenomyosis. Now, next question. 32-year-old woman nulliparous present with complaint of heavy bleeding for 8 months. She was using OC pills earlier but now wants to conceive, and TVS shows 4 centimeter submucosal fibroid. What is the treatment of choice? Yes. So when fibroid is associated with infertility, she wants to conceive, she's also having heavy menstrual bleeding, that's an additional pointer. But if it is protruding into the uterine cavity, you will have to go for surgical management, particularly because she wants to conceive. So in patients who are wanting to conceive, who are infertile, if that fibroid is contributing to infertility, it is better to remove it. Okay, surgical management is going to be preferred. And here remember, it is hysteroscopic myomectomy. Okay, now GnRH analog, while she is on GnRH analog therapy, ovaries are suppressed, so she will not be able to get pregnant, she will not be able to conceive while on therapy. And laparoscopic myomectomy will be done, let's say supposing it was an intramural fibroid, then we would have done a laparoscopic myomectomy, and embolization is not an option for those who are wanting to get pregnant in the future. Okay, and for those of you who are choosing option C as the answer, it is protruding inside the uterine cavity. Okay, then why do you want to go laparoscopically, cut through the uterus and take it out? Look at this image. This is the fibroid. submucous fibroid. Okay, this is the fibroid, this is the submucous fibroid completely inside the cavity, and this is completely intracavity. This is submucosal, this one is submucosal intracavitary type 0. Okay, there could be another one which is in submucosal type 1 and type 1. This one is type 0, this is completely intracavitary. There is another one which is type 1, right. Now these are inside the cavity, you can see the vascularity. Fibroids are vascular, can you see this, vascularity is distributed, peripheral vascularity. Okay, the periphery of the fibroid is the most vascular part, that we can appreciate on Doppler also. And this is the hysteroscopic image, same patient. So why would you want to go for laparoscopy here? Why would you want to go for laparoscopy? So this would need hysteroscopic approach. This would need hysteroscopic approach for myomectomy that can only be done in submucous type 0 and type 1 fibroids, FIGO type 0 and type 1. Okay. Now you look at this, compare this image, compare these two images. This is a fibroid. This is a fibroid, heterogeneous hypoechoic as compared to the surrounding myometrium. Compare it with this. This is whitish, this is hyperechoic inside the uterine cavity. This is hyperechoic inside the uterine cavity, there is a feeding vessel sign. This is endometrial polyp. This is feeding vessel sign. This is endometrial polyp. Okay, right, hyperechoic, and this is the hysteroscopic image of the endometrial polyp, very fleshy, very bright colored, like reddish colored like the surrounding endometrium, and this is endometrial polyp. Again hysteroscopic polypectomy will be needed for this. Again hysteroscopic polypectomy will be needed for this. Next question, 42-year-old woman complains of postcoital bleeding for the past 3 months. She reports that the bleeding is usually light but persistent. Which of the following is the initial step in managing postcoital bleeding? Yes, initial management in postcoital bleeding, straightforward one-liner question, straightforward question, nothing very difficult about it, nothing very difficult about it. Pooja, think again. Initial step, अरे भाई पोस्ट कोइटल ब्लीडिंग 42-year-old woman cervix नहीं देखना क्या, there could be cervical cancer, right? So look at it, per speculum examination, initial step. If on per speculum examination there is a growth seen, you can biopsy it, punch biopsy of the cervix. If per speculum examination is normal, then most of our Indian women will not have a recent screening result available. Please do some sort of screening for cervical cancer. Do some sort of screening for cervical cancer, whatever is available, whether it is a PAPS, whether it is a high HPV DNA testing. Do some sort of screening and wait for the results. Let her come back with the results and then subject her to colposcopy. Okay, but if she has persistent symptoms, but normal screen, then also please do a colposcopy, okay, then also please do a colposcopy, because negative screening in a symptomatic patient is not a very reassuring thing, okay. If there is a symptomatic patient, symptom cannot be ignored even if the screening results are negative initially. You can counter question me, then why do we go for the screening test? Because colposcopy, we are going for a visual inspection, okay, under magnification of course, but colposcopy, we are going to look at the cervix under magnification, form an idea about whether it looks like, you know, high grade lesion or low grade lesion. We are going to take a directed biopsy, okay, and then we need to go step by step. Alright. So, if I have an abnormal screening test report, like for example, if my screening test report had come as a high SIL, then I will be looking at my colposcopy in a different manner. I will be looking at my colposcopy findings. I will be more keen on evaluating one always wants to do a good job at colposcopy, but come to think of it, an abnormal screening test result has a potential of changing what we do in colposcopy. Like for example, if an abnormal screening test result shows atypical glandular cells, I want to add ECC along with colposcopy. You get my point, right? So that is why go step by step. So yes, colposcopy should be done, right? Okay, fine. Investigation of choice. Investigation of choice, I would say, with a postcoital bleeding with persistent symptoms, colposcopy would be something that is the gold standard. So I would say yes, investigation of choice. However, investigations of choices are always circumstantial. How best can I tell you this? There is an investigation of choice in a particular given situation, in a particular patient scenario. Investigation of choice is always circumstantial, my dear friends, right? And until unless there is a clear-cut blanket investigation of choice. Otherwise, it depends upon patient's clinical profile, it depends upon the resources also. So, you'll have to look at the clinical profile and answer, all right? Next question. 52-year-old, obese, hypertensive, an episode of postmenopausal bleeding. Cervix looks normal, flushed with vagina. Cervix looks normal, flushed with vagina. When I read this line that the cervix is flushed with vagina, it is a description of the fact that the cervix is very small and atrophic. Okay, so it is showing atrophic changes, which is fine for her age, it's okay. And her menopausal status. Uterus normal in size, adnexa free. Next best investigation for this patient. Yes, answer. Next best investigation for this patient. B and C. B and C. Okay, so I want to go for a, see, pap smear, 52 is not the peak age for cervical cancer anyways. Okay, there could be cervical cancer also. We've done a per speculum examination, so that's fine. Okay, so C is not the next best investigation for this patient. If you look at the profile, obese, hypertensive, अब ये प्रोफाइल किसके फेवर में जा रही है ज्यादा? It is going more in favor of endometrial cancer or not? Ruling out endometrial cancer is the priority, right? So, ACOG has come up with the latest update in this, and this came abhi kuch din pehle, April mein, that both transvaginal sonography and endometrial aspiration are a part of initial investigation. Both should be done, meaning that meaning that again, and I keep telling this to students, पहले भी ऐसे ही था, they have now mentioned it like this. Our practice was like this only, that one would always, the priority would be to rule out cancer, and endometrial cancer can also arise from from thin endometrium, from atrophic thin endometrium. Remember the type 2 histology. So both TVS and endometrial aspiration are a part of initial investigation. But if we have to pick one, then the answer is endometrial aspiration. Because even if the ET is narrow, even if the endometrial thickness is less than 4 mm, okay, even if it is less than 4 mm, I would still do endometrial aspiration. Also because of a risk factor profile. To that information, add the fact that she has a high risk factor profile. Okay, so endometrial aspiration can be omitted only if there is a single episode of postmenopausal bleeding. Single episode has happened, it is not ongoing and continuing. TVS is showing less than 4 mm endometrial thickness and clearly defined, it is there. She has no risk factors for endometrial cancer at all, and she is ready to come for follow-up. All of this has to be there, then only I can think of omitting. Okay, otherwise one should always include endometrial aspiration also as a part of initial evaluation. So when you think about it like this, you realize that in this question, if they had asked you if it was multiple options correct and they had asked you what is included in the initial evaluation, then TVS would have been included in the initial evaluation. Endometrial aspiration would also have been included in the initial evaluation. And if pap smear would also have been evaluated in the included in the initial evaluation for this patient. Multiple choice correct. But if you have to pick one, then priority wise endometrial aspiration becomes the answer. If no bleeding, do we prefer pap smear? Supriya, if she does not have postmenopausal bleeding, why will she come to you? Why will she come to the OPD? If she has no postmenopausal bleeding, starting point is postmenopausal bleeding. If she does not have postmenopausal bleeding, does she fit into the priority age group of cervical cancer screening? 52 ओके, मैं 49 तक है WHO के हिसाब से, हम 65 तक भी करते हैं स्क्रीन बेसिकली. तभी मैंने बोला ना पैप स्मेयर इनिशियल इवैल्यूएशन मल्टीपल चॉइस करेक्ट में, इनिशियल इवैल्यूएशन में पैप स्मेयर भी विल आल्सो बी देयर. बट अब इस कॉन्टेक्स्ट में तुमसे नेक्स्ट बेस्ट इन्वेस्टिगेशन पूछिए, नेक्स्ट इन्वेस्टिगेशन पूछिए, वन ऑप्शन यू हैव टू चूज, द आंसर इज endometrial aspiration. So for this particular patient, the investigation of choice is endometrial aspiration. It is circumstantial based on the patient's profile. Okay. All right. So this is the update. बच्चे, this is the update. हाँ, ET more than or equal to 4 mm में तो करना ही करना है endometrial aspiration, वो तो कोई डाउट ही नहीं है. But what the ACOG update has said now, that even in thin endometrium, do endometrial aspiration in the initial investigation itself. Do endometrial aspiration in the initial investigation itself. Endometrial aspiration can be omitted only if all of these are there. There has been a single episode of postmenopausal bleeding. It is not going an ongoing problem. TVS is because एक और चीज हो जाती है ना, क्लैरिटी नहीं रहती है कि व्हाट इज परसिस्टेंट सिम्टम. एक एपिसोड हुआ पोस्ट मेनोपॉजल ब्लीडिंग का, फिर दोबारा हो रहा है, कब तक हो रहा है, कब मानेंगे इसको परसिस्टेंट, उसकी कोई क्लैरिटी नहीं है. 1 महीने बाद करेंगे परसिस्टेंट, 2 महीने बाद मानेंगे परसिस्टेंट सिम्टम, 3 महीने बाद मानेंगे परसिस्टेंट सिम्टम्स, कोई क्लैरिटी नहीं है. इस एम्बिग्युइटी को हटाने के लिए उन्होंने बोला कि भाई पहले ही कर दो, फर्स्ट एपिसोड में कर दो TVS एंड एंडोमेट्रियल एस्पिरेशन. पेशेंट्स गेट लॉस्ट टू फॉलो अप ऑल्सो, प्रायोरिटीज इन रूलिंग आउट कैंसर. Okay, so that is your answer for this question and not many slides left. 3 ही तो क्वेश्चन बचे हैं, इतना ही बचा है. कहाँ गई पूजा? इतना ही बचा है. एंड हिस्ट्रोस्कोपी विद एंडोमेट्रियल सैम्पलिंग लिख लो, चलो बाद में नोट पढ़ोगे. हिस्ट्रोस्कोपी विद एंडोमेट्रियल सैम्पलिंग इज द गोल्ड स्टैंडर्ड. So a woman who is having persistent symptoms even after a normal endometrial aspiration, supposing we did an endometrial aspiration that came back as normal, but she's still continuing to have symptoms. So maybe there are areas inside that we missed, and then hysteroscopy is justified and must be done. 62-year-old, lean and thin, postmenopausal bleeding. Pelvic examination unremarkable. See endometrial biopsy done. She has been diagnosed with endometrial cancer. Even though cancer is confined to the body of the uterus, she has been told that the prognosis is poor. What is the most likely histology? We are building up on the previous question only. Building up on the previous question only, endometrial biopsy, endometrial cancer diagnosed. But the question is on histology. They are saying, look at this, they are saying cancer confined to body. Body of the uterus, meaning it is limited to where it began, must be stage 1. Even in stage 1, she has been told that prognosis is poor. Another very, very important factor that defines prognosis, a cancer, a type of endometrial cancer that spreads aggressively. What is that? Type 2 histology. Also going in favor, lean and thin, much older. Lean and thin, much older, 62 years, must be years after postmenopausal status. This is uterine papillary serous carcinoma. Endometrioid adenocarcinoma is obviously the most common type of histology. That is true. But here, serous histology, clear cell histology, the ones with P53 mutation, petals and places, you're rightly answering, is uterine papillary serous carcinoma. Now, from this question, let me also tell you one word about leiomyosarcoma, or let's say 3 pointers regarding leiomyosarcoma. Last FMG exam, they asked leiomyosarcoma. I was very surprised that they asked this too from FMG students, but that raises the possibility that they could be asking. Leiomyosarcoma. Myometrial tumor, okay, tumor, sarcoma from the myometrium, okay, sarcoma from the smooth muscle sarcoma, okay. So, important pointers that you should keep in mind. All right. Regarding leiomyosarcoma, important pointers that you should keep in mind is that, first of all, most of the women will be postmenopausal. Almost all will be postmenopausal. It hardly ever occurs in reproductive age group women. Most of these leiomyosarcomas arise de novo. Most are de novo. That means it's very unlikely that long-standing fibroids will eventually transform into leiomyosarcomas. It is very unlikely, right? So, most of these leiomyosarcomas arise de novo. Malignant transformation of benign leiomyomas is very unlikely. The other thing is that clinically they would present with a situation where a woman is having rapidly increasing size of fibroid, or she's becoming symptomatic, she's having postmenopausal bleeding. It will look like a fibroid that is increasing in size. She's having postmenopausal bleeding, or she's having pelvic pain along with it. Ultrasound, very confusing, it will look like a fibroid. MRI could help, but again not very conclusive. So, in these situations, hysterectomy is definitely needed. Hysterectomy makes the diagnosis. Hysterectomy is definitely needed. What we need is a hysterectomy. Final diagnosis can be made 10 mitotic figures per 10 high power fields is needed to make the diagnosis. Okay. Now, let's have a look at this question. 35-year-old choriocarcinoma 6 months after molar pregnancy evacuation. Ultrasound abdomen pelvis shows 3 centimeter diameter tumor, no other deposits. There's an isolated metastasis to lungs. HCG is 10,000, most appropriate therapy. Now, for INI-CET, again, basics of GTN, how to make the diagnosis, what are the findings, this is something that you must know. GTN is an important cancer. One upping, they tend to ask you clinical questions like this as to what would be the appropriate therapy, right? Now you have to choose between multi-agent chemotherapy or single agent chemotherapy. That is the choice. Most of the diagnosis is made by, the decision is made by modified WHO prognostic scoring system. The clue is to remember what gives a high grade. Okay, so you can see here that the event happening after term pregnancy, near to 12 months, you see beta HCG in lakhs, 10 to the power 5 is lakhs, 5 centimeter if you see. If you even remember these 4 points, 2, 2, 2, 2. If you even remember these 4 points, it will add up to a high score. The one that is developing after a molar pregnancy in a younger woman, small tumor, isolate the doubt here was about metastasis to lung. Isolated metastatic to lung. This is not isolated metastasis to lung. This is multiple metastasis to lung. This is cannonball metastasis to lungs. Many metastatic deposits are there in the lungs. Okay, when we are talking about isolated metastasis to lung, the site itself does not increase the score. Number of metastasis does increase the score, but site of metastasis alone does not increase the score. So that was the trick. This is a previous year question. So this was the only thing in the question which was tricky, right? So all the factors are giving possibly a low score. The only condition, the only doubt could have been about the lungs. So isolated metastasis to lungs, the site lung does not increase the score. So single agent chemotherapy, multi-dose methotrexate with folinic acid would be given. Okay, right? So in this manner, if you try to remember, you will not have to most likely mug up the entire this thing. I mean, if I had to ask about multi-agent chemotherapy, I would have framed the question years after delivery, after term pregnancy, choriocarcinoma developed, I would have given you the beta HCG in lakhs. And then you would have added up कि okay, अगर ये 4 भी जुड़ जाते हैं तो score 8 हो जाता है, right? So score of less than 6 we go for single agent chemotherapy, score more than equal to 7 we go for multi-agent chemotherapy. Okay, and cannonball metastasis is shown to you in one place, and in the other place you have these vaginal metastasis. These metastasis should not be biopsied. Remember another point, that these should not be biopsied. These should not be biopsied. Okay, clear? And then the last question for the day. A woman is seen with history of recurrent transverse lie in her 3 pregnancies. What uterine anomaly is most likely? Recurrent transverse lie. Which uterine anomaly is most likely? So malpresentations are more likely when the uterine cavity is distorted. Among the options, the uterine cavity is distorted in bicornuate uterus. So that would be your answer. Okay. Among the options provided, arcuate uterus, क्यों होगा arcuate uterus यार? Arcuate uterus is the mildest form of abnormality. Some even say that it is not even abnormality, it's just a normal variant. The cavity is more or less normal. The cavity is more or less normal. Okay, so answer is bicornuate uterus. It could be septate uterus में भी हो सकता है, septate में भी हो सकता है. Look at these images. Help you with image-based spotters. Help you with image-based spotters. This is wider angle, angle obtuse. This is likely bicornuate. This one here, acute angle, likely septate. I cannot say for sure on HSG. On HSG, 2 cavities, 2 cannulas seen. 2 cavities, 2 cannulas seen. Or they may say on per speculum examination, 2 separate cervices, 2 separate cervix on per speculum. Something or the other they should be there, or 2 cannulas should be seen. This is didelphys. This is unicornuate. This is unicornuate. Okay. Now, investigation of choice for Mullerian anomalies, 3D TVS. 3D TVS. 3D TVS images have not been asked so far. I think INI-CET would be the place to begin. That's why without going into too much details, I just put it as image spotters. Okay, just putting it as image spotters. This one here, This is the septate uterus. Okay, this one here, you see this bright white, this is the endometrium, bright white endometrium cavity basically, and this gray area is the myometrium. So here we are seeing a dip at the fundus. This is bicornuate. So on 3D TVS, we can appreciate the fundus. We can appreciate the uterine contour. This one here. Fundus can be appreciated. There's a slight dip here. Can you see? Can you see this slight dip? This is the septum, but it is very small. The septum length is less than 1 centimeter. Look at this septum length. This is a very long septum length. This is just septum length less than 1 centimeter. This one is arcuate. So I just put it as spotters. Okay. So from my side, I believe that these are the key important previous year topics considering the recent trends in the examination. I have also given you, along with the questions, dealing with the questions, the updates, the way these updates could be potentially formulated in the question, right? So I will share the PDF also. Right, so with this we finish off the session for today. I am very thankful to you people, those who have been responding in the chat boxes. You have been very kind, you have been very patient, you missed out on the break, but we were able to do as much as I had targeted that we will be able to do in this last minute recall session. Okay, so please remember guys that you have read well. I can get a hang of it from the PDF will be shared and the information will be provided to you. Don't worry. Okay, the concerned people will get in touch with you, right? Now, is this enough for INI May? How do you ask this question? Is this going to be enough? These are the most important PYQs. Okay, like for example, AUB they will ask you question, AUB evaluation, postmenopausal bleeding evaluation, APH, PPH. इन पे क्वेश्चन बनेगा ही बनेगा, जो गलत नहीं होना चाहिए. मुलेरियर अनोमलीज, प्राइमरी एमिनोरियाज, राइट? तो this is the bare minimum. Labor progress questions, right? Adenomyosis, fibroid differentiating pointers, right? So these are very basic pointers. We also did a lot today about aneuploidy screening, invasive fetal testing, right? So we have one upped, right? But let me also tell you कि बच्चे अगर आपका basic नहीं clear है, right? तो फिर इस तरीके की बातें करना that is this the only thing that is going to be enough? No, that is not a correct way to approach things, right? So clarify your basic, आप इसको करो. With this session you get an idea about how to attempt questions, how to read questions, right? मैंने कितने options को tweak, कितने questions में I tweaked the options and still you were able to attempt, answer correctly. That is the key for being successful. Now that you have the material, आप उसे रिवाइज कर रहे हो, बार बार पढ़ रहे हो, बट उसको पढ़ने का फायदा नहीं है, रिवाइज करने का फायदा नहीं है अगर क्वेश्चन पढ़ना नहीं आता, समझना नहीं आता एंड एलिमिनेट करना नहीं आता ना. दिस इज हाउ द एग्जामिनेशन पैटर्न इज. इट बिकम्स मोर अ टेस्ट ऑफ योर एग्जाम टेकिंग एबिलिटी रादर देन योर नॉलेज, है ना. वो उतने ड्यूरेशन में क्वेश्चंस को पढ़ना भी है, आंसर भी करना है. सो it is a amalgamation of the whole thing. Final selection. पढ़ तो आप लोग सब रही रहे हो, right? चलो, सेकेंड इमेज क्यों डायडेल्फिस क्यों लग रहा है भाई? इसमें एक ही कैनुला है, मैंने बताया ना क्लूज क्या होंगे. इसमें एक ही कैनुला है, इसमें एक ही कैनुला यहां से डाला, इसमें 2 कैनुला है, एक कैनुला यहां से डाला था, एक यहां से डाला था, 2 कैनुला की शैडो दिख रही है, 2 कैनुला की शैडो दिख रही है। और या तो ऐसा होगा, और दे मे टेल यू दैट on per speculum examination 2 separate cervix were seen, or they may tell you on 2 separate cervix were seen. ठीक है, चलो देन गाइज, योर टाइम इज वेरी प्रेशियस। 12 बजे से 5 बजे तक बैठे हुए हैं हम। आई थिंक नाउ यू शुड टेक your break, and you can find me on my personal, you were asking me where do you find me for your doubts and everything. You can find me on, this is my personal Telegram group. Find me under this name. You can post your questions, queries, doubts here. This is my personal Telegram group. Okay, there is also a Telegram channel from the app also. You can find me there also. All right. Okay. Thank you, Petals and Places. Thank you very much, guys. And Petals and Places, nice. Your name and your place are going together. Thank you. Chalo, goodbye. Bye-bye. Take care. All the best for your exams.